Hello, welcome everybody. All right. Hello, I'm Scott Perkins. I'm the co-director for Operations and Development at the Center for Medicare Advocacy. And it is my pleasure to welcome all of you here to the 12th Annual National Voices of Medicare Summit. As you know, this year's theme is Allies, Advocacy, Action. And I am thrilled to note that we are sharing today's program with over 1,600 allies from across the country, including representation from every single state. Yeah. So to all of you here, everybody on the live webcast, thank you, each of you. Not only for being here today, but for your commitment to the incredible work that we're doing together. For those of you joining virtually on the live webcast, just a quick reminder to be adding your questions to the on the online function for your questions as we get to Q&A. And I think next, I just want to take a moment and thank some of our sponsors, starting with Arnold Ventures, our inclusivity sponsor. It is because of their support that we are able to share the summit with 1,600 allies. We are able to share it widely and at no cost to attendees. So we thank you for that support. Next, I'd like to thank two of our networking sponsors. Our partners at the Christopher and Dana Reeve Foundation, and our good friends at Rothkopf Law Group, who are celebrating 25 years of providing advocacy in New Jersey and Pennsylvania. Thank you. So now with allies assembled, I'd like to get us started on sharing best practices for advocacy and action. It is my pleasure to kick us off by introducing our first team of presenters. My friend and colleague, CMA's co-director for Law and Policy, David Lipschitz. And Tricia Newman, Senior Vice President and Director of Medicare Policy here at KFF. Please join me in welcoming these two stellar advocates as they frame the day for us.
Hello, everyone. Thank you, Scott, and thank you, Tricia, for joining us once again and for all the fantastic work that KFF does, keeping us informed about Medicare and Medicaid and the Affordable Care Act and health care in general. And Scott, it just occurred to me when you said Allies Assemble that was a play on the Avengers, right? Okay, I got that one. All right, good, good. We've had the good fortune of having you multiple years. Might seem tedious to you, but it's a benefit to us. Fantastic. Helping us set up the day for this conference by talking about different Medicare issues. Today we're going to do things a little different. Medicare is in the name of this conference. It's in the name of our organization. It's in your job title. But we're not going to start off talking about Medicare. Rather, we're going to talk about Medicaid. Because there seems to be a lot going on at the moment with Medicaid. So I thought long and hard how to phrase my first question to you. I drew on all my years of experience in health policy to craft the question for you, and here it is. What the hell is going on right now?
This was not scripted, just to say the obvious.
Yeah.
First of all, I think I need to say welcome to KFF and the Barbara Jordan Conference Center. It is always great to have you here. So welcome, everybody. A lot of old faces, some new faces. So yeah. I've had the pleasure of coming to the summit for, I guess, a dozen years. And this is the first time I've been asked about Medicaid as an opening question. And it's because while we're here with the Center for Medicare Advocacy, There's a lot going on with Medicaid as we speak. There are significant reductions to Medicaid that are being passed by House committees at this moment. There are changes in rules that are going on. We're talking about close to $800 billion in Medicaid cuts. And at least a part of these cuts and rule changes have a direct effect on people with Medicare. So that is why we're here. We're here to talk about Medicaid, to understand the connection between sort of what's going on in the ecosystem and what it means for the people who we all spend our time working for.
Okay. So let's briefly talk about what some of those Medicaid cuts are before then turning to people specifically with Medicare and Medicaid. So what's on the table as part of this reconciliation process that's designed to try to find funding for various priorities of the administration, including extension of 2017 tax cuts, different border security, defense priorities. In order to do that, Congress needs to find a way to pay for it. This is part of the process. A lot of cuts are on the table. What are some of them with respect to Medicaid?
Well, one of them that has more of a direct effect is the eligibility and enrollment rule, which is really adding without it, there will be more red tape for people, making it difficult for people to get Medicare savings programs benefits and connect that to low-income subsidy benefits. So that's one thing. We can talk more about that or not. That's on the table. But that's significant savings, which also includes other populations. There are work requirements, which we think of like, well, that's not really a problem because it's for people under age 65. But if you broaden your lens a little bit and you're not just focused on people 65 and older, there are about 20 million people who are 50 and older who do get Medicaid benefits. And so it's this group of older people, 50 to 64, who could be affected by work requirements. This is a group that may or may not have difficulty finding a job. It's not so easy for older workers to find jobs. These are people caring for their aging parents. So it's not just younger people who are affected by that, it's older people too, even if these are not necessarily people 65 and older. There are broader cuts to Medicaid that may or may not affect the Medicare population, but they could, and we can talk about it, because if states are under greater fiscal pressure because of the magnitude of cuts that are coming their way, then states will have really tough decisions to make. Do they cut optional benefits? Do they cut optional populations? Do they cut payments to providers? Or do they raise taxes? None of those are easy choices, and they all have implications depending on who you're most concerned about. Should we go on?
Yeah, well, let's circle back to those Medicare-related ones in a moment. But you mentioned work requirements. There are also requirements for more frequent eligibility checks, which have really just been shown to cycle people off of Medicaid coverage, including those who are eligible for it, but for whatever reason can't complete the paperwork in time. There's going to be required cost sharing, if this goes through, for those in expansion Medicaid with incomes over 100% of the federal poverty level. There's going to be a freeze on states' ability to collect additional taxes from providers, which most states use to supplement their Medicaid funding. There is a freeze on the requirement of minimum nurse staffing ratio in nursing homes, which would have led to a lot, I think, better care, better outcomes, as Toby can certainly inform us about. We're going to talk a little bit more about the provisions directly related to Medicare, and there's a lot of good work being done by a lot of Medicaid advocates to raise awareness of these issues. But since Medicare is in both of our names, not our personal names, but that would be a good gimmick, wouldn't it?
Tricia, Medicare, Newman.
I think that flows quite nicely. The Congressional Budget Office has estimated that the impacts on Medicaid would likely lead to 8.6 million people becoming uninsured by 2034. And if you add in the fact that Congress is unlikely to extend certain credits for the Affordable Care Act and finalize a certain rule, that could be up to 13.7 million people who will be uninsured as a result of these policy changes as of 2034. So just as in life, oftentimes if someone makes a change over here, it has both intended and unintended consequences over here. So let's talk specifically about people with Medicare and Medicaid. I know you have a lot of good data for us. I'm going to pick up the clicker,
Okay.
move to our first slide. Let's first, oh, that's not the first slide. Let's first talk about who we are talking about.
Okay.
Who is duly eligible for Medicare and
I
Medicaid?
should just say, David would not let me come here without having some slides. He thought I. So, I mean, the big picture here is we're talking about roughly 12 million people. These are the lowest income people on Medicare. They generally have low assets. It's about 1 in 5 people nationwide, and it's about 1 in 5 people on Medicare. Just one thing to notice here that doesn't get enough attention, which is people under age 65. A much larger share of this population relies on Medicaid to supplement Medicare. So this is a group of people that could be particularly vulnerable to reductions in benefits that are optional benefits, home care benefits, caregiving benefits, that not only make Medicare work, but make their lives work by supplementing Medicare, because as you all know well, Medicare doesn't provide extended home and community-based services. Medicare doesn't provide caregiver support or the kinds of services that are needed. So I just want to emphasize that one particular point.
Thank you. Now we will move on to your slides, which was a great idea to include in this
Thank you.
presentation, by the way.
Thank you. I thought of that.
Yeah. That's a snapshot of who the dual eligibles are, but what does Medicaid spend
Right.
on people who are duly
So
eligible for Medicaid?
I'm sure you all have seen this before, but I think what is important to point out is the population of people who have Medicare and Medicaid account for a disproportionate share of Medicaid spending. Those are the right two bars. Sometimes we think about that within Medicare, but because Medicaid cuts are on the horizon, I think it's important to look at the for me, that's on the right side. Medicaid enrollment, these are people with Medicare and Medicaid, are 14% of the Medicaid population, but almost 30% of spending. So when you see the reductions in spending filtered down, I think it's pretty hard to imagine that segment of the population will be fully insulated.
So we looked at a snapshot of who comprises the duly eligible population. We looked at a snapshot of how much Medicaid spends on them.
Can I pause right there?
You may.
It's not just spending on Medicaid, but also think about spending on providers within the state, because this does spill down on providers. It spills down. Medicaid is 19% of national spending for hospitals. It's more than 40% on spending for nursing homes, and it's, I think, 60% for home care. So when there are cuts, it may affect people directly or indirectly. So it may affect if hospitals see cuts. You can imagine that there could be spillover effects in terms of services quality, who they're treating. If nursing homes see cuts, and nursing homes are also not going to be required to staff up, you can imagine what this might do for quality of care in nursing homes. That's obviously something that should be monitored.
Great point. Totally threw me off my game, though, as far as the flow.
Sorry.
But that's okay. So we took a look at who's duly eligible. We took a look at how much Medicaid spends. Now let's take a brief look at why Medicaid spends so much on people who are duly eligible for Medicare and Medicaid. Then you can make those points again, too, if you like.
He's trying so hard to script me. I mean, again, I feel like this is a little bit known to this audience, but if you look at the top green bars, so the green bars are characteristics of people with Medicare and Medicaid. The blue bars are people with Medicare but not Medicaid. And the point here, just if you look at the bars and no numbers, is the bars are bigger for people who with Medicare and Medicaid than they are for everybody else. That means they are sicker, they have greater needs. So let me just point out two of them. 41% of people with Medicare and Medicaid self-report being in fair or poor health, compared to 15% of Medicare beneficiaries without Medicaid. They are a sicker segment of the Medicare population. And then jumping down below, look at functional impairments. About a third of people with Medicare and Medicaid have 2 or more functional impairments, which indicates that they, have limited ability to do activities of daily living for themselves. Also, it's sort of a predictor of need for medical care. That compares to 11% for everybody else. So this is a population we're mindful of because this is a population that's relatively sick and has significant needs, both medical and long-term services and supports.
So let's circle back to what we started talking about the potential indirect impact on people who are duly eligible for Medicare, Medicaid from these rather significant cuts that are on the table. And then I want to talk about the direct impact, some of the provisions that are specifically addressing Medicare beneficiaries. So what are some of the indirect effects? If you have all this, if you have $700+ billion taken off of the table from federal Medicaid money, how are states likely to react?
Well, you think that was a setup kind of a question?
It was a softball.
It's a softball. I mean, look, states are going to have to do something, and a lot of states have to have balanced budgets. So the question is, what are they going to do? And I mentioned this a while earlier. I mean, maybe some states will find a way to, cut something else to keep things whole. But in all likelihood, states are going to have to cut people, cut services, cut payments to providers, or increase taxes. And so that is almost predictable with this level of savings. So you can sort of see that come down. We've sort of seen this before, and I think we're likely to see it again.
Yeah. So those are some of the indirect effects. It's very hard to see how that wouldn't play out this way,
Yeah.
particularly with the Medicaid cuts, particularly with the cuts to the Affordable Care Act, to SNAP program, and other things contemplated
Right.
in this legislation. And there is I think a thought that, well, Medicare isn't directly impacted by any of this, but there are some provisions, specifically in either the Energy and Commerce package or the Ways and Means Commerce, that does directly impact Medicare too. And I want to touch on those. You talked about one of those. There was a provision in there about Medicare savings programs. These are the programs that help many people pay for their Medicare expenses, premiums depending on the kind you have, cost sharing. There's a proposal to suspend the implementation of a rule that came out in 2023 that was aimed at trying to get more people enrolled in the Medicare savings program. Because what, about half of people all eligible for Medicare savings programs are not enrolled due to various reasons? This rule was crafted to make it easier for folks to get on Medicare savings programs. That rule is delayed under this proposal for 10 years as a budgetary savings measure. That is a direct hit on Medicare. That is going to lead to people who would otherwise be getting financial assistance to not get it if that is finalized.
I mean, what that rule would have done is it was estimated to help 1 million people get benefits to which they're entitled, but it's hard to get these benefits, as you know, and others know who are working with people. There is a lot of red tape, and there's a lot of sort of anxiety about applying for programs. So this will make it that much harder for people. So this is, as close to a direct impact on people with Medicare as you can get, because these are low-income people who may not have the resources to have a friend who's a lawyer who will go through some steps with them, or might not be able to call one of the two of us to say, how do I do this, which my friends now do. And so it does impose a barrier and makes it harder for people to get benefits that they are entitled to.
I want to touch on a second provision in these whole packages that directly impacts Medicare beneficiaries, and that has to do with an immigration-related proposal that was in the Ways and Means package. There's a provision in the Ways and Means proposal, and some of us are still trying to parse out exactly what it means and what it would do, but essentially it looks like that it would terminate coverage for immigrants who have been lawfully living, working, and paying taxes in the U.S., sometimes for decades. Now, the minority staff of the Senate Finance Committee, the Senate Budget Committee, and the Senate Aging Committee put out a summary of some of these changes. And so I'm going to read directly from their summary, assuming that they have a better understanding on what it does. So that provision, that was in the Ways and Means package, terminates Medicare coverage for refugees, asylum seekers, and people with temporary protected status from Ukraine, Sudan, and other war-torn countries. This undermines the Medicare guarantee, they go on, and takes away coverage from people who work and pay into the Medicare program. If that's not a direct attack on Medicare and has provisions to remove people from Medicare coverage within a year of enactment, then I don't know what is. There's another direct attack on Medicare, but that was part of the Energy and Commerce bill. I'm not sure if it made it through the markup, but having to do with drug price.
Can we pause on that one
Yes,
for a second?
yes.
I mean, I think there's sort of I've not seen language like this in the years that I've been working on Medicare, where there's a potential to take something away from somebody who's already on Medicare. I'm not an immigration expert, so I cannot speak to how many people are potentially affected and who exactly would be affected, because you have to be legally residing and a permanent resident in order, and paid your payroll taxes in order to get Medicare in the first place. So I kind of invite everybody here to sort of put a face on who might be affected by this. But the other thing that worries me about this is it authorizes the Social Security Commissioner to identify people who might meet the criteria defined in this language and notify them that their benefits are being terminated. And with the exchange of data that's going on at a pretty high level with immigration, my larger concern is that people who are here legally and entitled to Medicare may get pulled, I'll say accidentally, that they shouldn't lose their benefits, but they do because of a mistake. And then I can only imagine how much work everybody in the room is going to have to do to reinstate people to get them the benefits of Medicare coverage.
Thank you. Well, there's one other provision that may or may not have made it in the markup that they went through the night to do, having to do with Medicare drug price negotiation. That would limit the Secretary of Health and Human Services' ability to negotiate certain drugs. But we will skip that for now. We're going to hear a lot more about all of this soon. But I think one other point for dual eligibles is that these changes that are all on the table, that are very, they are in play. They are being debated at the moment. It's not just going to impact a small group of people in isolated parts of the country, right?
People with Medicare and Medicaid are everywhere. We've put out this map, which is congressional districts, so that members of Congress could know how many people in their districts do have Medicare and Medicaid. So a couple points. One is duals are everywhere. They're in every district. And then the other point I want to make is that we've also put out a lot of polling, and I'm sorry I didn't bring polling here, but Medicaid now polls really well. People who are Democrats, Republicans, independents don't want to see Medicaid cuts. In fact, a small share of Republicans and Trump supporters, like 30%, say they support Medicaid cuts. What has happened over the years is more and more people know people who are covered by Medicaid, either in their family or their friends. And so the idea, the prospect of a Medicaid cut gets very scary. And I think, and this might be something you want to talk about, that is why it's being framed more as fraud, waste, and abuse, because I think there is an understanding that Medicaid coverage really matters to people.
Yeah, and the point about fraud, waste, and abuse is a lot of the proponents of these policies couch it in terms of we're just going after the bad guys, we're just going after fraud, waste, and abuse. But KFF has put out papers on both fraud, waste, and abuse in Medicare and Medicaid, and essentially there's not much there. There is some, but a lot of it's incorrect paperwork, and by no means is there a level of fraud, waste, and abuse to justify the level of cuts that are currently on the table. And one last point about Medicaid. As a lot of people know, it has different names in different states. A lot of people might not necessarily realize that their Medicaid is being cut. They might be on TennCare, they might be on Husky Care, they might be on Sooner Care. So it's important if you're in a state that uses a name other than Medicaid, to make sure people know what the Medicaid program is locally. Now that is a very quick and dirty overview of some of the most pressing things going on in the health policy world at the moment. A cut to Medicaid is a cut to Medicare. But now, in our remaining minutes, let's turn back to our comfort food. Let's talk about Medicare.
I thought you were going to mention grits, because that's
Grits.
my comfort food.
Really, where'd you grow up?
My mom was from Alabama. So.
Okay. All right. Yay for Alabama. Let's turn back to kind of a general, broad picture of the Medicare program, and one of the biggest dynamics that is happening in the Medicare program is its privatization. You know, Medicare, of course, just for the basics, right? People have the option of enrolling in a private Medicare Advantage plan or in sticking with traditional Medicare. What is happening with that dynamic now, and why?
Okay, well, as you can see here, more than half of all people in Medicare are now in a Medicare Advantage plan. Medicare Advantage enrollment has been rising quite rapidly. It is projected to continue to rise rapidly. This is happening for a lot of reasons. It's happening because Medicare Advantage plans are able to offer extra benefits that people find are super appealing. Who wouldn't want vision, hearing, and a gym membership? For real. They do this without charging an additional premium. They also are able to offer reduced cost sharing. So that is all very appealing. They're able to do this in part because of the current payment system, which MedPAC has pointed out has Medicare paying roughly 20% more per person who enrolls in a Medicare Advantage plan than for people in traditional Medicare. That's roughly $80 billion this year, just in 1 year. So there's money in the system, and there are requirements for plans to put money back in the form of offering extra benefits, so people are able to get these extra benefits and not pay for it, and that's appealing. Also, it's one-stop shopping, and let's face it, Medicare's gotten way too complicated, and if you can sign up for one plan instead of A, B, let's see, Medigap G or whatever, and then Part D and all the plans there, this is you go to one place. But I think I'd like to emphasize a little bit the half of all people who are not in Medicare Advantage, because I think in some ways, like in Cinderella, that's like the stepsister. It's Cinderella, because...
That brings up the next slide nicely.
Thank you. That brings up the next slide. Traditional Medicare hasn't gotten a lot of attention. Medicare Advantage is the shiny nickel. There's lots of talk now about building up Medicare Advantage, using Medicare Advantage to provide more extra benefits. It's sort of the pathway to the future. I think if there should be a discussion about what should be the role of traditional Medicare, how should traditional Medicare be strengthened so it is an option for people in it, relative to Medicare Advantage. And I just want to point out, because we just put this out, my colleague Jeannie Fugelston-Binick did this. She was looking at rural beneficiaries, and 58% of rural beneficiaries in really rural areas are in traditional Medicare. So if we want to make Medicare work for people where they are and based on what they prefer, that might be something to think about. And it's not something that's getting a lot of attention. And on sort of along those lines, there has been some discussion about what the Center for Medicare and Medicaid Innovations might do in the next few years. And there's talk about default enrollment into Medicare Advantage for people newly coming on for Medicare. That will no doubt accelerate the trend that we saw in the last slide and increase the number of people who will be in Medicare Advantage. They will probably have the option to switch plans or opt out, but I kind of leave it to you who are working more closely with people to figure out how that will actually work. We also, just to put out a plug, we put out a paper that just raises a ton of questions. If the government is going to assign people to plan, how do they decide which insurers get which people? How do they align people with plans that include their drugs or the doctors that they see. So there are a lot of questions to work out in order to make something, to operationalize this and make it really work for people. But meanwhile, even without that, we are on a pathway forward, and without a change in law, without a change in payment policy, that could unravel. And since Chiquita is here, I just want to also put in a little plug. The other thing that we're watching is the administration the last administration put in a lot of new reporting requirements that would make it much easier to understand the value of extra benefits. Are people getting these benefits? We have no information to assess this stuff, and I think without information, we're a little bit where we are completely unable to assess really how well the program and these benefits are working for people, and that's a lost opportunity.
Thank you. And one thing I would love to see, paper idea, is more on what do we lose as traditional Medicare becomes more and more marginalized? What are some of the things that traditional Medicare does that there's not really an incentive for for-profit private plans to do?
Well, I mean, a big thing for people say that having a choice of provider is really important. People want to be able to choose their doctors and specialists. And by definition, people who are in Medicare Advantage plans have a more restricted provider network. They are also more subject to cost management tools like prior authorization, which just makes it that much harder to get the care that they need or results in delays in cares. What's kind of interesting this past year is I feel like the provider community has perked up on this, and the provider community has started to speak out about denials and delayed payments that make their lives more difficult and actually have a financial impact on hospitals, nursing homes, and other doctors that take Medicare patients, other providers that take Medicare patients.
So we'll be talking more about Medicare Advantage later in the day. In this in this environment where a lot is going on at once, let's take a quick snapshot at what's on the horizon. We talked about reconciliation.
Check.
We talked about Medicare Advantage. Executive order on drug prices that came out this week. Anything you want to say on that?
Yeah, just really briefly, an executive order came out on most favored nation status is kind of the whole idea. This is an idea that the Trump administration put forward in 2018. It was blocked by the courts for process reasons. It was then the rule was rescinded. There are a lot of questions about this. The executive order is very vague in terms of which drugs, which drug companies, which price, which countries do we look at for prices, and really how does this interact with the ongoing Medicare negotiations program, which is not as simple as it sounds. So, and that is something I know folks on the Hill have really been asking, because we do have, they just put out guidance. The administration just put out guidance on the Medicare negotiations program, which will include Part B drugs now. So things are moving forward. This administration has been defending the law in the courts. So there is a real question about how to sustain current law and what will this look like. And until we see more specifics, it's hard to say that much more.
In our remaining couple minutes, I think we have to mention the government restructuring and staff reductions. There have been tremendous cuts to staff at Health and Human Services and a lot of associated agencies. What does this mean for the administration of the Medicare program? And before you get into that, I also have to say, we also have a leaked budget, proposed budget for next year, that zeroes out funding for the state health insurance assistance programs, the SHIP programs, the only neutral and unbiased source of information for Medicare beneficiaries in the country. Your thoughts in 10 seconds or 15 seconds.
Okay.
Yeah,
I can't
no
even
pressure,
do that.
no pressure.
I'm freaking out here. There's not only what's going on within HHS, because there are a lot of offices within HHS that have direct roles in supporting Medicare. ASPE, ACL with the SHIPs, obviously CMS. There have been a lot of terminations, people retiring with expertise. But I also want to point out that Medicare relies on the Social Security Administration to do a lot of work in signing people up, working eligibility, premiums. So cuts in staff or reductions in staff at Social Security could have direct effects for Medicare beneficiaries if they're unable to sign up. DOJ, by the way, goes after fraud, right? So I don't really know what's going on with the staff at DOJ that have traditionally gone after Medicare fraud, but for a government that cares deeply about fraud, waste, and inefficiency, I would think that would be an office that you would want to sustain. So broadly speaking, there are a lot of cuts, there are a lot of restructuring. There's a lot of restructuring going on, and there are direct effects, but there are other indirect effects on the operations of Medicare that deserve attention, and some of that should get attention probably when the next budget comes up, because that's really where Congress will have an opportunity to push back on the funding for the agencies.
Final point before we wrap the panel up. We didn't get a time to address what is not on the horizon, but would it be safe to say that we're not likely to see much coverage expansion, both of people? I did on purpose. Thank you for pointing that out, though, Judy. She mentions I skipped the trustees report
paying attention.
for time. Yes, but thank you. There's not a lot on the horizon that we can talk about that expands the benefits. And on that really uplifting note, please join me in thanking Tricia for joining us on a panel today. Thank you, Tricia.
Thanks for having me.
Thank you. So before I get off the stage, or we get off the stage, for now, I'd like to introduce our next panel. We are thrilled to host a discussion between two Medicare program vets. We have Chiquita Brooks-LaSure, currently a senior fellow at the Century Foundation, and until January of this year, the administrator of the Centers for Medicare and Medicaid Services, CMS, and Sean Kavanaugh, former director of the Center for Medicare at CMS, current chief policy officer at Aledade, as well as his most important role, a member of our board of directors. Please join me in welcoming them.
Hello, hello.
So, welcome everybody. I'm sure Chiquita has a million things to say about everything we just heard.
I do.
But before we do that,
Did well, Tricia. That was a lot. That was very impressive.
sure, if you bring slides, you can. But before we do that, I wanted to talk a bit about the position you used to hold. Having worked at CMS, it's hard for me to convey the complexity and the enormity of the position of CMS administrator. If you think of Medicare, Medicaid, and the exchanges, growing to close to 200 million people, well north of $1 trillion, but also each of them has a very different statutory, regulatory, and operational construct, and you're supposed to run it all. Having said that, I was looking in preparation for this back, reminding myself, I've known you for a long time, but reminding myself of your career. And it occurred, like, if you were going to sort of plan from earlier in life, like, I'm going to be CMS administrator, what are the various boxes I should check on the way? Well, I might want to work at O&B at some point, probably need some Hill experience, probably need some CMS experience, probably need to know both the exchanges and Medicare and Medicaid. I mean, pretty extraordinary how, you know, I imagine the search from the Biden White House, like when they started going through this, it's like, oh, it's Chiquita. But the other thing, to go back on a more serious note, because this was very meaningful to a lot of my friends and colleagues at Aledade, was you're the first African American to have been administrator. Can you talk to us a little bit about what that historic first meant to you?
You know, I don't think it wasn't until I was nominated that and as time as being CMS administrator, really understood how important it was to other people to see me in the role. And I remember when I was a kid, I read a lot of biographies, and I remember reading about so many people who were firsts, a lot of women and a lot of people of color. And I thought, I'll never be a first when I grow up because all the barriers will be, will be broken through. And then when I became a first, so many people found it meaningful. Some of our staff, and certainly when I would meet people across the country, I remember two stories in particular. One when I was doing an event with Senator Wyden, and someone came up to talk to me, and she just burst into tears and apologized and said, it's just incredible to see someone who looks like me in your role. And my last year as CMS administrator at an event, someone came up to me and said, not only are you African American and woman, but you have a complicated name. And I have a complicated name. And she said, and you could have gone by your middle name. And it was so interesting because I do have a very complicated name. And there have been times in my life where I thought about my middle name by birth is Lynn, so I could have gone by Lynn, and then you all would be able to say my name easily. And I thought, here is a way that I am showing representation and being there for people by showing it's okay to, you can still achieve with not looking like everyone else. And I think that my own experiences, and not that my experiences match that of every other African American in this country by any stretches, but it was a powerful understanding that people want to be seen. They want their leaders to have some perspective about their lives. And the more that we diversify who comes to the table, who speaks at the table, we get better results. And I really was very fortunate that we were able to have a more diverse team at CMS, and the Biden administration overall just continuing to bring additional voices to the decision-making table because it's important.
Amen. Thank you for that. So before we pivot and think about a lot of the same things Tricia and David were talking about, let's look back. You just, still fairly recent that you concluded 4 years at CMS. Looking back, whether it's Medicare or Medicaid, any of the programs under your jurisdiction, what are you proudest of that you accomplished?
Yeah, I look back and I feel like we left it all on the field. I am really proud of our 4 years. And not that we did everything perfectly, but we tried and we accomplished some great things. I actually am so thrilled that you guys already talked about 2 M's. There's nothing that makes me happier than multiple M's in a conversation. So I have no favorites, as I say, so we'll talk about all of them. I'm so proud of how we strengthened the Medicaid program. It's not just that we hit record numbers of enrollment, but I think the rules that we set in motion, which I know are, under discussion, was really about raising the bar about what we expect out of the Medicaid program. And I think Medicaid has shifted. It is different than the program it was before the Affordable Care Act. Tricia talked about this a little bit, but I will just say, I don't think people appreciate how much Medicaid is really fundamental to our providers in this country. I did a lot of traveling and hearing from rural hospitals. There's a huge difference between the states that have expanded Medicaid and those that have not. And we really did up the bar in terms of what are the requirements for states, really trying to make sure that Medicaid is meaningful, not just a card in your pocket, but that you can actually go see the doctor. So super excited about what we were able to accomplish in the Medicaid program. We hit the lowest uninsured rate in our nation's history between the Medicaid program and the Affordable Care Act. Very happy about all of that. And then on Medicare, drug negotiation for the first time we did it and we did it well. I am very proud of the job that the team did on negotiating and creating a new responsibility at just really rapidly, executing really well, and I think we would not have been able to pay for the changes to the drug benefit if we had not really taken on the task of trying to tackle drug costs. And this year, the out-of-pocket cap in Part D is $2,000. This is life-changing. It's really a big deal. I'm sure this audience knows because you focus on Medicare, but I don't know that people appreciate how many drugs the average senior takes in this country, and just how crippling these costs are for a lot of our families. And it's not just the Medicare beneficiaries themselves that are paying this cost, right? It's the sandwich generation that's trying to figure out, how do I help my mom and dad afford these drugs? How do I also make sure my kids get into college, and all of that? It is a multi-generational thing, and I'm really proud of us taking those important first steps of the first 10 drugs, and the law is still the law of the land, and hope that those continue. So those are my three highlights. There, we could go on and on, but those are the big.
I would ask you to touch on one other highlight, which
Yeah.
was you and the whole administration were very intentional across your portfolio of programs of trying to make sure the programs worked for everybody, meaning that there were no missed populations, that, diversity, equity, and inclusion. Even in my program, which is about value-based care, there were elements of making sure we were targeting underserved areas, also providers who serve underserved areas. Do you want to mention something about your DEI initiatives?
Absolutely. I think that from not only for the people, but also for our healthcare system, it is crucial that we really make sure it works for everybody. And I think that there can sometimes be the perspective of government of just, well, I sort of say, throw it over the transom. Like, this is a good policy and people will take it up. And that's not how the world works. You have to go out of your way sometimes to engage and make sure that you are designing things so that everybody can benefit from them. And we really saw this, we all have seen this in various places, but COVID-19, it's hard to believe, but when we came in, the vaccines were just around the corner. They weren't even, it was just when certain populations could get the vaccines. The amount of time that the administration had to spend to make sure that the underserved got the vaccines and were getting treatment, it took a lot more effort, because it takes more effort to reach some of the underserved, and you have to be intentional, again, not just for those people, but if you don't want the hospitals full of sick people, you have to go and make sure that the underserved are getting the treatments, getting the vaccines, getting the treatments. And so really in every conversation, every decision, really, I like to say, kicking the tires and saying, okay, have we thought about, can everybody access what we're trying to do? Have we asked the questions? And particularly in the Innovation Center, really starting to look at the data, and absolutely credit to Liz Fowler, who said, let's look at our models, and have we looked to see who's in them? I mean, we had a model for maternal health where everybody in it was white, right? Like, that's not where our crisis, not every single person, but mostly, I mean, a vast majority. And we have a crisis with our Black and brown moms, and really making sure we are answering those questions, asking ourselves those questions, and then saying, what do we do about it? And most people who are underserved are served by a certain set of providers. We also have to make sure we are bringing them along as we come up with these incredibly important innovations. We need to make sure they're part of that conversation.
So as you said, you spent 4 years, great team, as you, in your words, left it all on the field. There's an election, there's change in administration. And now we're in the situation that David and Tricia were describing. So let's reflect on that a little. What of the gains that you and the Biden administration made are you most worried about? And any other perspective on what's happening in Medicare, but as Tricia pointed out, the Medicaid implications for the dually eligible?
Well, I would say what I'm most worried about is really our coverage losses that potentially could come. And I would say coverage is necessary, not sufficient to a healthy world, right? But it is the starting place. And I think all of us can really identify with the frustration of the level of friction that we have in our world in general, but definitely in the healthcare system. And if we have time, we can talk at length about prior authorization and just some of those aggravations. But if you go through the eligibility process, it is really challenging. And I think I would say just some of the reconciliation bill is just like death by 1,000 cuts to Medicaid and the Affordable Care Act coverage. And, for so many people in our country, they've got a ton of things going on, right? And you should not be spending all of your time figuring out, did I fill out my paperwork properly, and being worried, because that drives so much of the bankruptcies in this country. We did the Affordable Care Act because a third of the bankruptcies during the Great Recession were the result of healthcare, and it's still a very high percentage today. So I'm really worried about just adding the red tape, even when you're trying to do it well, like we in many states during the unwinding of Medicaid, the COVID rules where people had to do eligibility determinations. We lost millions of people because of paperwork. And so the idea that we're forgetting these lessons, which are incredibly recent, and then talking about adding additional barriers is deeply, deeply concerning to me.
So just at a brief aside of how much the landscape can shift. 25 years ago, I lived in New York City, and I had a job working for the city, and my job was to help get rid of all the red tape so we could get all the kids, especially kids, on CHIP and Medicaid. And the mayor at the time was leading the initiative and railed against all the friction that you're describing. That mayor was Rudy Giuliani. This is the only time I'll ever mention that. You mentioned prior auth, and we have a little bit of time, so let's go there. The program, Medicare specifically, as Tricia's data showed, is increasingly becoming a managed care program. And yet at the same time, I think, almost on a bipartisan basis now, people are chafing under how prior authorization is actually operationalized. You guys took some actions to try to provide more transparency, expediency, and so forth. What were you seeing, and what do you think is going to happen going forward?
Well, I would say that prior authorization is bigger than Medicare. It is an issue in all of the in the commercial market and some of the other payers. But when I would talk to providers, they felt by far that the most friction that they were experiencing was in Medicare Advantage. And Tricia touched on this, and I will amplify. Providers are so angry about prior auth. I did so many conversations, and one that really sticks in my mind was at a cancer center, and just they were showing me a chart. Nobody is excited about cancer treatment, right? They're not looking for the shiny new thing. And they walked me through the steps that it took to get somebody on their cancer treatment. The oncologist talked about how 50% of their time was spent on this. We do not want our oncologists spending 50% of their time going through prior authorization. And just like frustration over how much the back and forth and why are you rejecting the claims. I think that that's why it's a bipartisan issue, because people are really frustrated. And I personally am very agnostic about whether Medicare beneficiaries want to choose Medicare Advantage or traditional Medicare. Just think there should be an option for both. And there are things that MA plans provide that are good things that honestly I would say need to be in traditional Medicare. And we tried to do those through the Innovation Center, but the Innovation Center still has a lot of requirements around it about saving money and budget neutrality. And some of those things, again, I think need to be part of the core benefit. And MA plans often can provide those things. And so people are attracted to those plans, but we can't have it where you can't see your doctor. And too many times I would hear about situations where doctors were telling people, oh, you're in MA and now you have cancer. You got to get out of it and you want to be in traditional Medicare. And as you all know well, switching between the programs sometimes is not easy. You don't want to switch when you're sick. And so I think that back to prior auth, I think this is something, again, that's larger than the Medicare program that needs to be tackled. But certainly with in MA, we have got to make sure we are preserving the core of the Medicare program, which is if you are older, you need to be able to see providers to treat the conditions that you have. And we need to, for the sake of the beneficiaries and for the sake of our healthcare system, make sure that our prior authorization has a common sense element to it, that it's really keeping, waste, which there is, it's not that providers are perfect. Sometimes there is a place for prior authorization, but it can't be so burdensome that we lose our providers in our healthcare system, or that it's really interfering with care.
We only have a couple minutes left, so I'm going to talk fast.
Okay.
What's your quick take on an issue Tricia and David touched on briefly? There's been a lot of reorganization, a lot of downsizing of staff, both targeted and untargeted. As the former operator of the agency, or what do you think of what you've seen? Any thoughts of what the implications for both policymaking, but also the operations of the programs going forward?
Well, every administration has a right to make changes and adjustments, and that's the joy of being in control. That you do have choices, and I would just say that they need to be done really thoughtfully. And I am deeply concerned. I'm probably more concerned about some of my sister agencies, who obviously CMS works very closely with, but the changes at FDA, CDC, NIH, they are deeply concerning from a, what is our cancer treatment going to look like on the long term? Some of these changes are just really going to be devastating to our healthcare system. Around Medicare, specifically, some of the staff that were let go at CMS are the people who are the most responsive to members of Congress or to issues for Medicare beneficiaries or providers in our regions. That's where a lot of that work is done. The first round of losses at CMS were really very personally distressing to me. One of my now colleagues at the Century Foundation, Emma, was in that first round. That was some of our best and brightest. We had spent a lot of time getting those people in because CMS had been under a hiring freeze for 2/3 of our staff. We had worked very hard to bring in another round. And I think what was just so distressing is that it wasn't based on performance. It really was, you're temporary, and it was easy. And so I just feel really strongly that, again, an administration has a right to make changes, but they need to be done incredibly thoughtfully and just because you don't have Medicare or Medicaid in the title of your job doesn't mean that you don't work on those programs, because so much of the work is interdependent. ACL's changes have huge implications, and CMS is now absorbing a lot of other programs, and there's nothing inherently wrong with that, but CMS already has had a flatlined budget for a lot of the core Medicaid and Medicare work, and then so to be adding additional responsibilities without changing the budget, how are we expecting that the agency is going to do the work that it needs to do for the people that are served by its programs?
And in conclusion, you mentioned you're at the Century Foundation now.
Oh, yes.
With a couple other all-stars. What are you
Yes.
all working on?
Well, I think one of the biggest things we want to do is just continue to be a voice and speak to the moment of what's happening and really reminding people what the stakes are. We met yesterday to just talk about all of the provisions. We all focus on health, listening to some of my colleagues about what some of these other committees do that I'm not really, it was pretty shocking just to really look at across our economy, just some of these pieces. So we will continue to do our work of trying to highlight what's happening and what this would mean to the American people.
I'll conclude with one more anecdote about the job that you so capably fulfilled.
Yeah.
A while back, I was the deputy director at the Innovation Center under my friend Rick Gilfillan, and I don't think Rick would mind me telling this story. And he had a meeting coming up with the administrator, a one-on-one. And so he said, we got to sit down. I got to bring to her, and this was Marilyn Tavener at the time, I've got 15 unsolvable problems. I can't bring 15 to her. Let's get it down to 10. So we spent all the time. We got it down to 10, and then I sent him off to the administrator's office. And then he comes back in a couple hours. I was like, how did it go? He's like, well, I was in line with Cindy Mann from Medicaid, and she had 10 unsolvable problems. And John Blum had his 10 unsolvable Medicare problems. And he's like, thank God I'm not administrator. But thank you for being administrator.
Thank you.
We're done, and we'll turn it back to the CMA staff.
Hi, everyone. I'm Eric Krupa. I'm a supervising attorney with the center. Thank you all for being here today. It's great to be around so many people who care about these issues, are coming at it from different perspectives, different roles. I'm with the Center for Medicare Advocacy again, rejoining earlier this year, and this is my first in-person summit. So in particular, it's really good to be with you all here today. I'd like to take a second to thank the Alzheimer's Association for their support and their mission to end Alzheimer's and other forms of dementia. Our longtime partnership means a lot to the center. And now I'll introduce our panel, Pathways to Advocacy, led by CMA's Kata Cortez, who's our managing policy attorney. We also have Dr. Ed Weisbart, who serves as National Board Secretary and Missouri Chapter Chair of Physicians for a National Health Program. Unfortunately, Amy Hall can't be with us today. She's Minority Staff Director of the Subcommittee on Health within the Committee on Ways and Means for the U.S. House of Representatives. She understandably has a lot of work to do right now. But graciously filling in is Kathy Hurwitz. She served for 20 years as Chief of Staff to Representative Jan Schakowsky, where she's a strong advocate for universal health care and senior and labor issues. She's now a board member for Healthcare for America and CMA, and she's the treasurer of the DNC Seniors Council. So with that, I'll turn it over to Kata. Thank you all again.
Thank you, Eric. As Tracy mentioned, I'm Katja Cortez, Managing Policy Attorney at the Center for Medicare Advocacy. Welcome to the panel, everyone. We're here to discuss different pathways to advocacy as a means of striving for meaningful pathways to change, achieving substantial improvements to our healthcare system, eliminating harmful barriers to care, improving access to necessary treatment for all beneficiaries, supporting aging with dignity, and bolstering robust quality of life for beneficiaries and their families. Kathy and Ed will discuss how advocates can push for these policy changes that improve lives, including grassroots advocacy, presenting proposals to Hill staff, building coalitions, and spurring momentum behind proposals. Kathy and Ed will address how advocacy strategies must respond to the challenges presented by the environment we're currently inhabiting, including the tax bill that touches on Medicare and Medicaid. But they will also infuse hope into our discussion, relaying the best approaches for coming together as a community, pushing back on harmful changes, while striving for impactful, positive improvements to our healthcare system. And with that, I'll turn it over to Ed.
Hello. So, I'm Ed Weisbart. I'm a family physician in St. Louis, and I'm the National Board Secretary for Physicians for a National Health Program. And I think I'm here to talk to you about, our organization is about, I would say, 6 years into an intentional transformation from a research and education foundation into a direct advocacy organization. So I want to talk a bit about how we went through that, what we've been driving through that, what the mechanism for that's been, and what this means. I'm hoping that will serve as an example for other organizations that might also want to do that. So we started, as you may know, in 1987, really research and education centric on Medicare for all. As our past president, Phil Verhoff, said recently, when he first heard the organization talking about Medicare for all, his first question was, have you told anybody about this? Because he thought if you heard about this, of course you would want to support it. So we just have to tell people. And that was frankly our strategy for a long time. If you build it, they'll come, crossing one leap across the chasm. And that was the right strategy because nobody really had been talking about it. And then the Sanders campaign happened, and regardless of what you might think of him as a hero as I do, that changed the landscape of what Medicare for All's, how people understood it. And it took us a little bit of time to figure that out, that had happened, but then we embarked upon a very thoughtful, intentional change of our organization with all the things you go through in the first phases of that, a SWOT analysis and all of that stuff. And then about a year after we began that, we thought we're just chomping at the bit to do things, and we started what we called the kitchen table campaign, which was rather than talking just about Medicare for all, we decided, well, let's talk about what people are talking about. What are the healthcare issues that are on their table, and then show them the connection between that and Medicare for all, and all the things you would think, surprise bills, equity, reproductive freedom, a whole suite of these topics that were evidence-based, chosen by evidence of what's on the kitchen table. And there were two key things that we learned from that. The first was we acquired a whole bunch of skills that we didn't have. We developed a skill at making quick videos, long videos, talking points for radio interviews in multiple languages, a whole suite of tools that we developed. So that was great. We still have those skills. And then the second thing we learned was slow down. We were so eager. We had literally 6 campaigns over 6 months. We thought we would build a campaign, we would put it out to our chapters, and they would be so happy with that they would then run off and do all these things for a month, and then change gears to a different topic, and then the second month, so we learned, no, that's not the right approach. But that got us ready for then the next year when we learned about the direct contracting entity thing that President Trump invented. I guess his team invented in 2020 and got, well, we won't do the content on that, but we decided that was a major direct threat on traditional Medicare that nobody seemed to know much about, and Rick Gilfillan actually kind of got us hip to it. And we decided to focus on that. So we made that our focus of advocacy work. I'll explain how that fits in just a moment. And we focused on that. I think we had a significant impact that evolved into ACO REACH campaign work that we've been doing. So that was our focus for quite a while. And then we recognized that actually is only a prelude to what we started talking about a bit today, the Medicare Advantage piece. And we looked at privatization writ large. It's everywhere, of course, it's everywhere, and decided we can't focus everywhere. We decided to focus on Medicare Advantage. That was one of the lessons from our kitchen table campaign is no, you can't focus on everything. Pick the thing that you think is the most important. So we did, and then that led us to where we are today, which is what we sort of capsulized as our triple aim that really organizes how we approach things. So I want to explain what that means. So we still have as our central focus, of course, the thing that we're organized around, single-payer Medicare for all, but we've decided that, Teddy Roosevelt campaigned on national health insurance, and he lost the 1912 election. So we should learn that that's not an adequate strategy. So instead, we've got three aims. We're fighting the profiteering and the privatization, and we're trying to use that funding and that's to improve traditional Medicare in the ways that a few people have already mentioned are so desperately important. And by profiteering, we focused specifically on Medicare Advantage. And on improving traditional Medicare, it's the things that you all are intimately aware of. And we believe that those two pieces are instrumental that's the best roadway to moving us forward. But we also realize that there's like a brick wall between here and there. So to cross that brick wall, we decided we needed more power. And we're very specific about that. So we think we need to be bigger. We are now about 26,000, mostly physicians around the country. But there's like 1 million physicians in the country, most of whom agree with us. But we need to be bigger. We need to be more powerful. If we can go to Congress with 100,000 voices, that would be much more effective. So growing our membership is sort of a core of what we're focused on. We needed to have more resources. So we're a group of doctors, so it's absurd that we had to tap that more. And so because of our focusing on tapping our physician membership, we now have more national organizers, which empowers the rest of our plan. But because of some of the work I'm going to show you, that also made us a friendlier group for some of the grants that we're fortunate enough to be able to work with. And Arnold Ventures, hooray for them, and Robert Wood Johnson Foundation. So I'll talk about that a bit. We also decided we needed to have a broader connection to legislators, and so we've been working quite actively on that. And lastly, we're no longer sort of viewing ourselves as the lone voice out there, but we're recognizing we have a very specific role within the advocacy community writ large. We'll come back to each of those pieces. But this broader vision, this triple aim, I want to show it a little different way, has allowed us to reach into groups that we've not been able to reach before. So rather than only talking, if you ask us a question about a policy 10 years ago, our answer would be, it's not single payer, so we don't like it. And that's not the way to get people to keep asking you for a point of view. So profiteering is really an important piece of what we want to expose and fight about, and it has opened up all sorts of doors and communication and dialogues with people that are really close allies, even though they don't necessarily agree with our intent that those fundings should be redeployed into improving Medicare. And that's fine. There's a whole lot of common ground on exposing and fighting the profiteering and privatization, even among people who don't agree with us about that second circle. And not everybody who wants to improve traditional Medicare in the ways that we've been talking about, not all of those folks, probably not everybody in this room thinks that that's important because, in part, it's a way to get towards single payer. So that's great. We can talk about this in these broad ways. And the point is that there's a bigger audience that we can work with and we can move into. So we found this strategy to be really, really important. We began the work by thinking, are we just doctors doing the usual thing, talking about health outcomes and making people healthier? First of all, are we talking about more money or less money? And we were very disturbed by the MedPAC reports showing, $80 or more billion being squandered, but yet members of Congress saying, yeah, it's overpaid, $10 billion on upcoding. Well, MedPAC says like 80, and you're saying 10? We saw a huge disconnect there. And so we decided to focus on that, and then our analysis says that MedPAC is really probably underestimating it. We think it's more like 140 billion because of categories MedPAC doesn't include in their analysis at the end of it. So we started there, giving us the confidence to say this is budget neutral or budget favorable, what we want to do. This isn't, this is a very reasonable, conservative, friendly approach, which we didn't know until we analyzed it. And then that led us to the question of, well, but we are doctors. What's the health impact of Medicare Advantage and profiteering and privatization? And we discovered it's overwhelmingly dangerous. Medicare Advantage isn't just a crazy waste of money, but it's incredibly dangerous. It hurts people, and in our report you'll see compelling evidence, I think, that it actually kills people, that it's completely unacceptable to me. And yet, I see the trade-off. I see the overfunding does provide the extra benefits, so it's not an easy piece, but that's why our triple aim is deal with privatization, but use that money to give people a safe landing pad back in traditional Medicare. So these are integrated things, but we needed to expose the harm. We thought that was all we had to do. We thought, go to Congress, talk about tens of billions of dollars, 80 billion or 140 billion, and it's killing people. Of course you're going to join on board. But the common pushback that we got that we were hearing was, but the disenfranchised communities in our country are seeing Medicare Advantage as a solution or a step forward on that problem. And equity is the main thing that they don't want to hurt. And guess what? We don't either. But they didn't see this argument that it's killing people. I thought that was enough. Anything that kills people is not a solution to equity. That doesn't work that way. That didn't land. So we decided we'd do a deeper dive onto that, and that's what we are about halfway through this report that we're planning to release in September, really looking closely at the impact of Medicare Advantage, specifically on the inequities, specifically on the black population of America. And it's pretty striking what we're learning from this, and I have to really give a shout out of thank you again to Arnold Ventures for funding this report. And remember, Arnold Ventures, spectacular, driving a lot of positive progressive change in the country and enabling. It's great. I can't speak for them, but I don't think that they're really a single payer-centric organization. And yet, this is a great example of the common ground. We have this thing that we're working on in commonality with them, and they funded this report, which we'll be releasing late August, early September. And then we have the joy of another great grant from Robert Wood Johnson Foundation, looking at sort of the harm on physicians. It's not burnout. Physicians aren't burnt out from working too much. Physicians worked a lot in the 1950s and 60s and 70s. The problem of physician burnout is actually the moral injury of knowing how you can help somebody and having some greedy organization stepping in between you and saying, not so fast, don't help that person, because it's not profitable, and that's just causing moral injury. So we're going to do a really good academic study on this that we'll be releasing late this year, we hope. So how do we change the organization? Well, we are a physician-centric organization, as you know, so we want to use that asset. So physicians need to hear about science and policy, and so need to help develop that. So that's, of course, a big piece of where we focus. And they have narratives. We have narratives. The stories you just heard about cancer treatment and millions more. But we need to be empowered to raise our voices and tell stories that we can tell. I think that's very helpful. We need to amplify sort of exponentially our power by working through existing organizations, the medical societies that most of us belong to. We need to be raising our voices there. And we have a whole campaign organized around multiple pieces of that. And doctors went to med school, but we didn't go to poli-sci school. We don't have any idea how to talk to politicians or members of Congress. So we've been doing aggressive campaigns on educating physicians on how to meet with members of Congress. They are now becoming increasingly independent at doing that, so we can train other doctors at it. It's really growing. We're seeing that really grow. We have campaigns on how to learn how to write op-eds and all that happy stuff. Med students are sort of the voice of the future, and we want them to be embedded, activism embedded in their work. I view that sort of like the Federalist Society getting into law schools 50 years ago and not telling anybody that their goal was to reverse Chevron in the Supreme Court. So, we view this as a long-term piece that has immediate and long-term benefits, and frankly, the students I've learned so much from them. They're refreshing our whole point of view. And we have the fortune of chapter organization. We have chapters in almost every state, some more than one. This makes people getting engaged, personal, local. It gives them a chance to build skills, have an impact at their state legislatures in lots of things, and that's a great way for them to build relationships with Congress, too, doing it locally. And then we have national campaigns. Most recently, we did a shadow hearing exposing what we view as some of the concerns about Dr. Oz, and we've done other things of that sort that then people around the country build. But we really do see our role as one of many within this coalescence of organizations, and I hope I didn't leave anybody off of that, but most of us are meeting like literally every 2 weeks for the last 2 years, coordinating our work. Oh, you've got this, let me amplify that work you're doing. Oh, we've got this, can you amplify that? Here's tools we built. Oh, I like your tools. Oh, that's great. So we are actually really working together, and there's only so much more, there's so much more in the near future that we're just really excited about. So, hooray.
Thank you, Ed. Kathy?
Well, again, I'm sorry I'm not Amy Hall. I'm sure you would rather hear from her than from me. But what I want to do is give you a kind of my general sense of advocacy and then talk specifically about the reconciliation process, which is going on right now and will be going on for a while, and in terms of Medicaid. So in terms of advocacy, having been on both sides, I worked for Citizen Action at AFSCME, and I worked on the Hill for 3 different members of Congress. I think the most important thing is to know what you want and what you don't want, very specifically. Then you've got to know who can give it to you. We don't need 435 members of the House to vote with us. We need 218, normally. We don't need 100 senators, we need either 51 or 60. And so you need to target that. And then you need to be able to explain to the target that you have, the person you're trying to persuade to do what you want, why they should care about you. Maybe you have the expertise they need, you represent an important group of people or institution in their district. You may be thinking about running against them, I don't know. But you've got to be able to think about what your power is in terms of the person you're trying to persuade. So let me talk very quickly about Medicaid. You heard from everyone this morning why anybody who cares about Medicare should care about Medicaid. Let me add that the structure, when we hear about nursing homes closing, we hear about hospitals closing, particularly in rural areas. The people who suffer are not just people on Medicaid, it's everybody. So we've got to think about that. The importance of Medicaid in a recession is really important, and I'm not an economist, so I can't tell you, but there's some who say we may be heading there. That's really important. And when we think about, there's seniors over there, young people over here, kids over there. People live in families. And when people are hurting from a recession, they may not be able to help their grandparents or their parents. So we need to think about that. And just to be a little bit philosophical here, the idea that some people don't deserve health care, the idea that we should take health care away from people in order to fund tax cuts for billionaires or to reduce the deficit, when we let them get away with that, that sets the precedent for Medicare fights down the road. So I think we can't let them do that. So Medicaid. The idea about providing information to members of Congress and their staffs on Medicaid in terms of this reconciliation bill cannot be overstressed. I mean, think about this. The Energy and Commerce Committee, which is debating this right now, 17 members were not on that committee last year. That means they may have no expertise in Medicaid, and we know how complicated Medicaid is, right? They have no expertise. There was not a hearing held on the proposal. The bill came out Sunday night. They started marking it up Tuesday. You know that there are things in that bill that nobody knows about. We're all going to find that out, and we're going to be able to educate people about it. Advocating for no cuts. This waste, fraud, and abuse, and I was talking to Toby. We worked so hard on the nursing home safe staffing standards for years and years and years. That's labeled waste. I mean, literally, they say waste, we're gonna get rid of that. We cannot let them define waste, fraud, and abuse as taking health care and services away. And it's not just, as you heard this morning, it's not just a question of people losing total coverage. It's a question of people losing the benefits that they get, because if they're on Medicare, they get benefits through Medicaid that they wouldn't otherwise get. So we can't let them get away with that. We can say, if you want to get rid of waste, fraud, and abuse, let's talk about getting rid of Medicare Advantage upcoding and lowering prescription drug price. So we can define those terms ourselves. And I think, as Ed was talking about, we have a very, very broad coalition. It's not just that the public polling is supportive of Medicaid and thinks government should be doing more to get people affordable health care and comprehensive health care, but we have a very big group of people who are concerned about this specific bill. And here's where the hope comes in, okay? First of all, remember what happened when Trump first came in the last time. And everybody said, the ACA is done for. It wasn't done for because we all organized and we all did it. Prescription drug, you heard Chiquita talk about the Medicare price negotiation. They said it couldn't be done, and we did it. We can stop reconciliation. This is just what's going on this week with all the committees marking up, and they're doing horrible things on SNAP and other things. It's just the first step. They're going to package all this. They're going to take it to the House floor probably next week, and then it goes to the Senate, where Josh Hawley has already said he's not voting for Medicaid cuts. And Ron Johnson, Sarah showed me, Ron Johnson said this bill's going to be dead in the Senate. It's going to be dead if we all get together and fight on this and make our voices known and let people know what's really in this bill and how really bad it is. And I'm going to talk about, Ed talked a lot about the coalitions, doctors, hospitals, nursing homes, there are a lot of people who we don't normally work with, but one group of people we haven't talked about are state and local elected officials. Because what this reconciliation bill does is it shifts costs to them for Medicaid, for SNAP, for other things. They have balanced budget requirements. They shouldn't, but they do, which means that they're going to have to cut people. And again, going back to, if we're heading into a recession, it's particularly the worst time. So I actually think this is our and the other thing is, our power has already been seen by the fact that the Republicans don't want to say they're cutting Medicaid, right? So, we should feel emboldened, and we should feel energized, and looking at the impacts if we don't win, we should feel as committed as ever to fighting this fight, and I think we can win it. So thank you.
Matt, do we have questions online or Jeff in the room for our panelists here?
Oh, one second, your mic's not on,
We can't
Matt.
hear you, Matt.
Hello?
Yes.
Haha.
Okay.
Heard a couple words on this panel like equity and science that made me wonder how advocacy approaches have changed or maybe should change in order to respond to the current environment.
Both of you can go ahead.
My approach is double down on it. I'm sorry, equity is not a nice to have, it's a must have. We have to deal with these problems. Science, I won't even go there. I don't think there's any backing away. I think there's popular support for these things in general, actually, and I think that's just all the more reason for us to make the case and be more compelling and to escalate our use of these notions.
I'm not sure I actually understand the gist of the question, but I do think what is really important in healthcare is to be able to, at the same time, lift everybody up and recognizing that there are people who are not getting the healthcare that some of us get, but making sure that the solutions are universal so that everybody feels that they're going to be protected.
Any questions in the room for our panelists?
Yes, anyone have any questions in the room? Anyone? Matt, I can pass it back to you at this time.
I have one as a moderator. I'll take this opportunity. Can you both speak to the strategic benefits and challenges of embracing incremental change in policies upon which additional expansions can later be built versus larger, more comprehensive changes? Kathy, we can start with you.
All of a sudden, I remember that one of the founders of PNHP, Dr. Quentin Young, used to say you can't leap a chasm in 2 leaps. You have to do it from here to there. And I would like to agree with that, but having worked on the Hill for almost 40 years, I think we need to take steps. I think that prescription drug negotiation, one of them. I am a particular fan of doing all payer rates because I think that gets rid of a lot of middlemen and it gets a lot of equity and it takes away some of the discrimination in healthcare. I think we have to look. I remember when we passed the ACA and people said it wasn't good enough. And they thought that people like Dennis Kucinich would vote against it because it wasn't good enough. And the members sat around and they said, it makes a real difference to people. Passing this bill will improve people's lives, and we've got to do it. So if it's an incremental thing that moves people's healthcare in a better place, I think we should do it.
Yeah, you're right. That used to be sort of our organizational mantra. You can't cross a chasm in 2 leaps. But I don't know about y'all. I've been to the Grand Canyon. People that have tried to jump across, there's a lot of dead people down there. It's not how you cross a chasm, in my personal point of view. You get a rope to go across, and then you pull a bigger rope, and then you get a bridge. The point is, though, the rope has to go across the chasm. You have to actually be, direction matters. You have to be going in the right direction. So Medicare was incremental.
And can I just say that, incremental is not a dirty word. I mean, things like Medicaid expansion may be incremental, but it sure made a difference to millions of Americans.
Well, go back before Medicaid expansion. Medicare and Medicaid are not universal health care. They leave out most Americans. So, those are incremental changes. Should we, let's repeal Medicare because it's too incremental? No, but the key is we have to be thoughtful about what those changes are, and we can walk and chew gum. We need to simultaneously be tracking where we want to go. We know, just last week, the reintroduction of the Medicare for All bills was introduced with more than 100 people in the House and the largest number I think we've ever had in the Senate. So we need to keep those bills alive. We need to keep on moving that forward. But that's not the only thing we should be doing. We need to be. There's lots of other stuff. So I think we can walk and chew gum at the same time.
Great, Jeff, how are we doing on time? Okay, we have a question and one over here as well.
One question in the room. Here you go, Tatiana.
Thank you. I represent all the millions of people in California. 2 things, and I think this is directed to the medical community. Last year, scripts dropped out of all Medicare Advantage plans, and it left over 35,000 beneficiaries who were in Medicare Advantage to scurry to look for a new plan or revert back to original Medicare and find a provider that had open practice, number one. And number 2, they had no guarantee issued to get a Medigap because of that situation. So now it shifts to the policy because there is no special election period when a major medical group pulls out. So do you see any will to add more special election periods? Because, you know, I'm an educator for the California High Caps ship, and it's a really difficult question that we have to answer to our beneficiaries.
I mean, philosophically, I think if Medicare Advantage beneficiaries are being demonstrably harmed by some of the policies that have driven provider groups out, I think that just, I'm not an expert on this question, but I would support a thing that would say, yeah, you know, you should be protected against that harm. But more specifics I can't. Do you have?
But if you look at the reconciliation bill that's being debated right now, they're taking away special enrollment periods. So I think again, this is the difference of philosophy is that, you know, one side wants to make sure that people when have access to health care that's meaningful access, not a piece of paper, but there's no place they can go. And the other is trying to save money by restricting whether people can do that.
If I could make one more point on this, I thought where you were going to go was should there be protections in Medigap so that you do have guaranteed issue and community rating if you decide to go back. And I used to think that, but then I looked at the 4 states that have that, and as you could predict, they have higher Medigap premiums because, you know, adverse selection. So if you did that as a policy, you would expect premiums in Medigap for everybody to go up, which is the nature of insurance. Mm-hmm. And they also have higher Medicare Advantage penetration growing more rapidly because people are less afraid to join Medicare Advantage when they know they can get out. So a policy of supporting guaranteed issue and community rating around the country for Medigap would adversely raise premiums and actually accelerate Medicare Advantage adoption. So I would not support that as a direction.
I think we're out of time for our panel. I'm sorry for all the questions we couldn't get to right now. I think we're going to head into our break right now and return.
We will return at 1:50.
1:50,
so about a 12-minute break, everyone.
Okay,
thank you so much,
please join me in thanking them.
Folks can take their seats. Come on to your seat.
Okay, everyone. If you can make your way back to your seats and we'll get started again.
All right, good afternoon, everyone. Welcome back from the break. My name is Melanie Lambert, and I'm a senior Medicare advocate with the Center for Medicare Advocacy. I'm honored to be here with all of you today and grateful to be attending my first summit as a newer member of the Center's team. It's truly inspiring to be a part of a community so deeply committed to protecting and strengthening Medicare, not just as a program, but as a promise to older adults, people with disabilities, and future generations. Before introducing the next section, I'd like to take a moment to thank 2025 CMA Summit community sponsor, Powers Law. To everyone at Powers, we are grateful for your longtime partnership and support. Up next, we have our Community Voice section. This is a moment to hear directly from a community member that CMA has assisted. In the following video, we will hear from Lisa Strelecki, who is a nurse manager at Connecticut Children's Medical Center, and Christine Huberty, an attorney at the Center for Medicare Advocacy, who's currently presenting at a conference on the opposite coast, so she's not here today with us. Since joining the center, I've been struck by something powerful, the deep sense of shared responsibility that runs through everything we do. It's not just about policy or law, it's about people. It's about making sure that dignity, access, and fairness remain at the heart of our healthcare system, and that work isn't done in isolation. It's fueled by our partners, allies, and most importantly, by the voices of individuals from across the country who experience the realities of Medicare every day. And that's what the Community Voice section of today is about. This segment is a space for honoring lived experience and for reminding ourselves why this work matters so deeply. The center and our partners are here not only to advocate, but to listen, because it's the stories of our community that shape the fight for equity, accountability, and justice in Medicare and in healthcare. So thank you for being a part of this extraordinary community. It's a privilege to stand with all of you. And now I'm very proud to introduce Community Voice, a segment that reminds us who we're here for and what we're fighting to protect.
All right. Well, thank you so much, Lisa, for joining us today and for being willing to share your story and the story of your mom. Before we get started, if you could just tell us a little bit about you and yourself and where you're from.
Okay, sure. Hi, and thank you for asking me to participate in this. So I was born and raised in Connecticut. From a very young age, when my brother was hospitalized, I decided I wanted to be a nurse. And I subsequently went to St. Joseph University in West Hartford, Connecticut. And I started my career in pediatric nursing, and then very quickly realized I wanted to go work in the neonatal, the newborn intensive care world. So I went there like in 1996, so it's been almost 30 years. I'm married to my wonderful husband, Matt. I have two beautiful boys, Andrew and Thomas. And I currently work in a NICU at Connecticut Children's Hospital in Hartford, Connecticut.
Thank you. And so we asked you to share a story today mostly about your mom. And so before we get started with all of the Medicare issues, if you could just tell us a little bit about who she was, and especially before she started having the medical issues that led her to come to us.
Sure. So my mom was a wonderful individual, very family-centered. She was married, had 4 children. All of us are still alive and all live in the area. Unfortunately, my dad died after a heart transplant in 1988. So my mom, being the strong woman that she is, continued on and was very involved with her children and their families. She's Italian. She loved to cook and loved to, have us all over for holidays and events. But then Joan, the case manager, she must have told me this right before I left. She told me about you, Christine. She didn't necessarily say your name, but she told me the name of your agency. And she said it would be really helpful, probably for you, to call her and see what kind of support she could offer. And so after the funeral and I sort of recovered a little bit, I decided to call because we were devastated and angry, and I wanted to see what we could do. And so we called. Sorry. And I forget her name. The paralegal was extremely supportive and said, I think this is going to be a case we're going to take. And obviously, my first conversation with you was, yes, we can definitely help you here. And that was like the most positive thing we had had through this whole experience. And you my family still talks about you. We had never seen you, but we had certainly plenty of conversations about how lucky we were to have found you and to receive the support and direction and acknowledgement that, you know, you guys aren't crazy. This is real. Yeah. And obviously you worked a miracle and very positive things came out of that. And somehow after all of that, the insurance company decided, oh yes, we should definitely pay for this. So, a very stressful situation, but you helped to make it easier for us. And I know I've asked you this multiple times. What if I knew about you sooner? What could have helped us? Because even though I'm well educated and a nurse, and my husband's an insurance guy and well educated, it's really difficult to navigate. You don't know how to navigate this system.
Do you have any advice?
Obviously, for future, we know about you.
Right.
We're grateful for the opportunity to help Lisa and her family and other people, but it shouldn't require the intervention of a nonprofit law firm to help people get care to which they are entitled. Now, I would like to bring up some friends. Ben, Wendell, Jamila, come on up to the stage. To begin this portion of the summit, let's move around here so you guys can squeeze by. I'd like to take a moment to share some gratitude for our 2025 CMA Summit program sponsors and partners, Medicare Rights Center and Justice and Aging. I also want to thank our advocate sponsors, California Health Advocates, SMP, Senior Medicare Patrol, and Mansfield Family Practice. In addition, I'd also like to thank our Chiplin Social Justice and Advocacy Award sponsor, our friend and supporter, psychotherapist Jonathan Kirkendall. Thank you so much, John. During this segment, we are going to hear from Ben Belton, the inaugural Chiplin awardee and former CMA board member, who will share some remarks about our colleague, Chip, for whom this award was named. Then we're going to hear from our friend and colleague, Wendell Potter, President of the Center for Health and Democracy and previous Rockefeller lecturer, thank you again, who will help us introduce this year's Chiplin awardee, Jamila Headley, Executive Director of Be a Hero. And of course, we will hear from our Chiplin awardee, Jamila Headley, about which you will hear more. So Ben, why don't you come on up?
I don't know if you heard David just now. He whispered in my ear that he didn't talk trash about me this time, as he usually does. Well, thank you all so very much, and good afternoon. It's so wonderful to see you all. I see so many old friends and colleagues, folks I haven't seen in a while. I hope that you and your friends are all doing well. It's so wonderful to be here and to be in community with like-minded people. This really has lifted my spirits being here today. I also want to give greetings to our dear friends and colleagues who are watching us via the live stream. It's wonderful that we can have this hybrid approach to be in person, but also have our good colleagues and friends joining us from around the country. Let me first recognize the center staff who had anything to do with putting this program together. It's a wonderful program. I know you do a lot of work with logistics and programming, so why don't we just give the Center for Medicare Advocacy staff a big hand. And even you, David. I'm going to be really brief, and I just wanted to be here today to share a few words in honor of the memory of our dear friend Chip. He was a man who dedicated his life and his career to serving others. In these challenging times, I've thought a lot about Chip and his vision for our society to make our society one where we have health equity, civility, and decency, and really justice for all. So many people have a better quality of life because of Chip's efforts, his advocacy, and his action. People who are on Medicare, their families and their caregivers, thousands of people around this country are better off because of Chip. And he did his work quietly. He didn't need a lot of fanfare. He didn't need a lot of applause. He didn't even need to see his name in lights, which is one of the reasons why I love to always recognize him and his contributions. One of the ways that the center keeps his legacy alive is through the Alfred J. Chiplin Social Justice and Advocacy Award. I'll give anybody $20 if you could say that fast 5 times. This award recognizes someone who has made a lasting impact in furtherance of Chip's mission. Jamila, congratulations on receiving this year's award. Like Chip, you are a transformational leader. And thank you for the leadership that you have had in this country, but also around the world where your impact has been felt. I know Chip would have been so proud. I could see him now. He would have been beaming across this room with his smile, knowing that you are receiving this award in his honor. I know that none of us who ever worked with Chip will forget his kindness, his smile, or the courage he showed in the face of overwhelming challenges. Even near the end of his life, he kept showing up for others. I mean, he showed up for me the day when I received my award, and he gave me some really kind, wise words of encouragement that I carry with me in my heart even to this day. Even in the face of his own mortality, he kept making a way. And just thinking about him now just makes me really emotional because he told me that he was proud of me, and that is something that I have just never forgotten. His example inspires us to take action, to stay in the fight for justice, and to support those who need it the most. Even on tough days, his legacy motivates me to want to be a better person, to want to do better, and to want to make a difference in someone else's life. Now I have the pleasure of introducing another agent for change, someone who's no stranger to the summit, Wendell Potter, who is the publisher and executive editor of Healthcare Uncovered. He also leads the Center for Health and Democracy and the Lower Out-of-Pocket Now Coalition, and now is in all caps. Wendell isn't playing, he means business. That's my kind of coalition, Wendell. So thank you for all you do, Wendell. Jamila, it's wonderful to meet you, and congratulations for all your work. And David, I guess it's good to see you as well. Thank you all so very much.
Thank you very much, Ben. David, thank you all for this opportunity to introduce my dear friend and colleague, Jamila Healy. Jamila is a movement leader and remarkable strategist whose brilliant mind is eclipsed only by her generous spirit and her big heart. She regularly signs her emails with big hugs, and anyone who's worked alongside Jamila knows the sincerity and authenticity of her big hugs well wishes. I have a lot of great things to say about Jamila's leadership in the movement for health justice, but before I get too far into that, I want to wish her a belated Happy Mother's Day, as she is a relatively new mom to an adorable young boy. His name is Shiloh. Jamila, I'm sure that your husband Max and Shiloh and your whole family are all very proud of your work. And we in this room consider ourselves very lucky that we can share you and your compassion and brilliance. Jamila was born in Barbados and came to the United States to study at St. Michael's College in Vermont, where she got her bachelor's degree in political science. Shortly after her graduation, while surfing back home in Barbados, Jamila experienced a sharp cramp in her thighs, and hours later was in the hospital, unable to move her legs. She was diagnosed with a rare neurological disorder, transverse myelitis. Through the support and advocacy of her friends and family, Jamila was able to get the initial treatment that she needed, but this experience solidified what she already knew about the U.S. healthcare system. She said that for every miraculous story like hers, there are too many others who suffer a sure fate of death, of debt, of prolonged illness, or of death. But like many other great leaders in this movement, including Adi Barkan, Jamila decided to use her story and her personal experiences to fight for others, especially those who were left behind by the system. Jamila went on to earn her master's in global health and PhD in public health, in global health and a PhD in public health from the University of Oxford, where she studied as a Rhodes Scholar, the first female Rhodes Scholar from St. Michael's College. She began her career as a program officer overseeing public health programs at Open Societies Foundation, and then went on to become the managing director at the Health Global Access Project, also known as Health Gap, where she worked with movement leaders and activists from 15 countries across the world to fight for access to HIV/AIDS treatments and quality health care. Before coming to her role at Be a Hero, Jamila was the chief of staff at the Center for Popular Democracy and CPD Action, where she led fights to advance racial and economic justice and spearhead a pro-immigrant and pro-worker agenda. Jamila joined the Be a Hero team in 2021 as co-executive director alongside Adi Barkan. Jamila and Adi fought together to protect nurses, increase access to masks during the COVID-19 pandemic, expand access to home care, and ensure that our nation's care workers get the pay and benefits that they deserve for their heroic work. I met Jamila in 2023 when she and Adi added yet another important fight to their plate, taking on Medicare Advantage and fighting to reclaim Medicare from greedy corporations like the ones that I used to work for. For years, many of us have been looking at Medicare Advantage as a major concern. We discussed the urgently needed policies to address the growing privatization of an essential public health program. Jamila and Adi brought a whole new dynamic to that fight by bringing grassroots voices to directly impacted patients and beneficiaries to the table. They started to convene academics, policymakers, and organizers to tackle this very big problem. And over time, we coalesced on a strategy to save this vital program that we often refer to as traditional Medicare. Our work is ongoing, but the immense progress that we have made to raise this as an issue and build political support could not have been possible without Jamila's kind-hearted leadership and strategic planning. After Adi passed away in 2023, Jamila remembered him at his moment at his memorial by sharing exchanges that they had in the months before his death, in which Adi lamented that his illness kept him from doing everything that he wanted to do. Jamila said that she encouraged him and reminded him of his ongoing impact in the world, and that in true Adi fashion, he debated her. Later, he would follow up saying that he gained strength through meditating on the things that he was grateful for, and that he was re-energized by a new strategy to win on home care. Adi's passing was a sad moment in our fight for health care, but Jamila finished her remarks by saying that there is nothing more powerful than a movement of the brokenhearted. Jamila, I agree with you, but I want to add that without leaders like you, there would be no movement at all. This award is given to an individual who works to advance civility in society and social justice for all. Your ability to inspire hope when people are hurt, your determination to put power into the hands of people who don't have enough of it, and your courage to be bold, innovative, and inclusive of all voices is what keeps us on the path toward justice and healing. We share our times of grief and our moments of joy with each other because of the example that you set and because of the leadership you exemplify. Thank you for your advocacy, and congratulations.
Thank you, Wendell, and thank you, Ben. And is that the right one? No, wrong one. All right, this one, 50-50 chance. Jamila, it has been an honor and a pleasure to get to know you over the last few years. Adi brought a fierce moral urgency to his work that helped propel things, and I have no doubt after getting to know you that you have that same urgency, and that's what makes you so effective. On behalf of the Center for Medicare Advocacy, we are pleased and privileged to give you or honor you with this Chiplin Social Justice Award.
If someone had told 21-year-old AIDS activist me that one day a C-suite health insurance, former health insurance C-suite person would introduce me for an award, I would have said no way. But in all honesty, Wendell, it's been such a pleasure working with you, getting to know you, seeing your fierce clarity about what needs to change in our healthcare system. You're an important voice for our time, and we are really, really privileged to be able to work alongside you. I want to thank CMA for this incredible honor and say a little bit about you guys and what it's meant to work with you. We've been able to collaborate with the Center for Medicare Advocacy in the last few years, particularly on the Medicare Advantage fight. A few years ago now, me and Adi found ourselves enraged about what was going on in Medicare Advantage. And for us, we were now becoming aware of this huge problem that our friends at CMA had known for some time existed. But we felt like very few people understood the extent of the problem. Even the two of us who had been working in healthcare had very little understanding of what was going on with Medicare Advantage, and that almost no one was paying attention to the massive amount of fraud and abuse by health insurance corporations that was costing taxpayers tens of billions of dollars each year. But of course, CMA was already on the case, and minutes into a call with Judy and David, I remember Adi and I texting each other and being like, we found our people, you know? David and Judy and the rest of the CMA team, thank you for the many hours you've spent breaking down the intricacies of Medicare infrastructure and rules to us over the years. I feel like being really patient with my novice in this area. I thank you for the time that you spent strategizing with us and scheming with us about how to change this problem on Zoom mostly, for marching alongside us in the streets, and for sitting next to us in some boardrooms, whether it be meeting with the White House or CMS. And thank you especially for showing up for us in our time of immense grief in the aftermath of Adi's death, and stepping up in the work when we took some time to take care of our team and to grieve Adi's passing. It means so much to me to be recognized with this year's Chiplin Social Justice and Advocacy Award. I, unfortunately, did not have the opportunity to know and work with Chip, but he seems like exactly the right kind of combination of talent and deep care for others that we badly need more of right now, as we face down the most serious threats to our social safety net and to our health and well-being that this country has seen in generations. What an honor it is to receive an award in Chip's name and to be invited into this lineage of awardees I regard so highly as you continue to celebrate his legacy. Some of you who know me well know that I don't love giving speeches, so I'm going to cut to the chase here. I want to say more about this moment we're in, because I know many folks in the room and many of the virtual attendees are already feeling it acutely. Healthcare in this country was already in dire straits. We heard the story just now from Lisa and Joan. So many people suffering medical debt, too many people still uninsured, so many people skipping doctor's appointments, skipping doses of medications because they can't afford the care that they need. We were already in crisis. And I need now to be excruciatingly clear, so bear with me. Every single step forward we've taken together is at risk right now. Everything all of you have built, everything CMA has built over the years, everything that Chip worked on, and that countless patients and people with disabilities, elders, community organizations, and all of the unknown and unnamed heroes who have sat across from tables in offices, who have marched in the streets, who have
work to build and improve and deliver for all of us who now rely on Medicare, Medicaid, CHIP, or on the Affordable Care Act, and those of us who are counting on these safety net programs being there for us in the future. It's all at risk. And as you've already heard here, just this week, House Republicans released a plan to deliver $880 billion in cuts over the next 10 years to finance the extension of Trump's tax cuts for the wealthy. This plan outlines $715 billion in cuts from Medicaid and the Affordable Care Act, programs that together some 120 million people across the country depend on for health care. And meanwhile, and not unrelated, despite all of Trump and Musk's promises to tackle waste, fraud, and abuse in the federal government, in the 113 days since DOGE has been in existence, Musk and his team have failed to find perhaps the largest source of fraud in the federal government. The fact that the health insurance corporations are on course to fleece taxpayers of more than $1 trillion over the next 10 years through their fraudulent profiteering schemes in Medicare Advantage. Instead, Trump has proposed double the rate increase to Medicare Advantage insurers next year, while DOGE fires the already stretched workforce needed for oversight and accountability. There is no sugarcoating this. If Trump and Republicans in Congress succeed in advocating, in advancing this agenda, it will devastate all of us. Conservative estimates project that 8.6 million people will be uninsured in 2034 if this happens. The cost of healthcare will go up for millions of Americans. Hospitals across the country, particularly those in rural communities that are already struggling, will close. Nursing homes and healthcare centers that communities depend on will be shuttered. We will bankrupt the Medicare Trust Fund and put more seniors and people with disabilities in the way of deadly delays and denials of care by private insurers obsessed with their bottom line. Millions of people will forgo going to the doctor. Hundreds of thousands of people will be unable to get the home care they need or afford the medicines that keep them well. Many more families will be crushed under the weight of medical debt. Many, many people will die. The agenda that's being advanced is abundantly clear. There is a faction, a powerful faction of the Republican Party that wants to dismantle social safety net programs that serve America's most vulnerable and the working poor. They want to redirect the federal government and hard-earned taxpayers' dollars to lining the pockets of the wealthy. You see, oligarchs have no use for Medicare or Medicaid or Social Security or the ACA, because they don't believe that these programs serve them. And they see government and all of us, the people of this country, as vehicles for serving them as they work to amass power and wealth. So yes, everything we fought for, everything we've won, it's all at risk right now. And yet, I have hope. And I want to tell you why. Adi, my friend Adi and former co-director of Be a Hero, quoted Rebecca Solnit ad nauseum, like to the point that I was like, you're really obsessed with her, you really need to stop quoting her. And now, in this moment, I found myself rereading her book, Hope in the Dark. And in that book, she says, to hope is to give yourself to the future, and that commitment to the future makes the present inhabitable. Anything could happen, and whether we act or not has everything to do with it. I have noticed wars will break out, the planet will heat up, species will die out, but how many, how hot, and what survives depends on whether we act. It's painfully true. There has never been another moment exactly like this one in the history of our country. But there's some good news. Musk might be the richest person in the world, but this country only has 800 billionaires, and there are tens of millions of us. We outnumber them. This is our power. It has always been our power. And the fight will be hard, and it will be exhausting. But my hope is not naive. I have hope, and it's not the one that's fluffy and warm and fuzzy. It's evidence-based hope, and I use that term because I'm in a room full of people who like to talk about evidence-based stuff. I come from a tradition. I like to say I was raised by AIDS activists. I come from a tradition of health justice advocates that saw pharmaceutical companies were killing people with AIDS by pricing life-saving antiretroviral medicines out of their reach. Activists from groups like ACT UP in the US and France and the Treatment Action Campaign in South Africa, Health Gap, and many others around the world exposed farmer greed and took bold, relentless action in a fight for their lives. Here in DC, they staged sit-ins in government offices and they filled the streets with protests. They lobbied Congress and loudly shut down political rallies across the country. They even delayed the opening of the stock market. They got arrested, they got released, and they got arrested again. And they did not stop fighting until things started to change, until the drug prices came down here and for people all around the world. And then when I was 21 years old, I had just been awarded a Rhodes Scholarship. I was sort of on the top of my game. I finished college a semester early and suddenly became paralyzed due to the onset of a severe neurological condition called transverse myelitis. I didn't have health insurance at the time, and it was terrifying. These were the days before the Affordable Care Act. I ended up getting the care I needed and amassing more than $1 million in medical debt. And due to the kindness of strangers and a whole lot of luck, I received charity care that wiped my debt away. But I also knew I was now uninsurable in this country. Fortunately, I was able to take up my scholarship and go to the UK, where I benefited from the wonders of the National Health Service universal health care program. But because of the work of so many advocates who fought for the ACA, and particularly people with disabilities who put their lives on the line to fight for that legislation, a reality that at the time felt intractable shifted fundamentally. My pre-existing illness no longer disqualified me from getting the coverage that I needed in this country. And then 7 years later, in 2017, when Congress and Trump tried over and over again to repeal the ACA and rip health care away from millions of Americans, activists, led again by disabled people, organized, told their very personal health care stories, showed up and put their bodies on the line, and we saved the ACA. Courageous action delivers wins. It always has. It's the only thing that has. We have faced dire moments before this one. Together, we've held off threats to our health and our communities, and that's what keeps me in the work and what gives me hope. But I have to tell you, there is no room for people on the sidelines on this fight. Right now, we need to be braver than ever before. We need to be more courageous than ever before. This is the time. They're coming for Medicare. They're coming for Medicaid. They're coming for the ACA. They're coming for Social Security. And if they succeed in delivering on this agenda, it will devastate all of us. And it will take generations to recover. In an interview a few years before he died, Adi said that he was not optimistic about the future. He couldn't predict how it would go, but he said that he was hopeful about it. Adi believed that hope was not a state of mind, that it was a state of action. Optimism is hard. Adi said in a quote later, "Optimism is hard for me to find these days, but hope is another thing entirely." Rebecca Solnit wrote, "Hope is not like a lottery ticket you can sit on the sofa and clutch, feeling lucky. Hope is an axe you break down doors with in an emergency, because hope should shove you out of the door, because it will take everything you have to steer the future away from endless war, from the annihilation of the earth's treasures, and the grinding down of the poor and the marginal. Hope just means another world might be possible. Not promised, not guaranteed. Hope calls for action." So today, I want to take a moment. I want you to take a moment to answer this question. How are you going to take courageous action? Just take a moment. Think about it. What are you going to do? And then whatever action you imagine taking, I want to invite you to do something even more courageous than that. More courageous than you have ever done before. If you've never picked up the phone and called your member of Congress, now's the time to do it. If you've never gone to their office again and again and showed up outside there until they spoke to you, now that might be your next act. If you've never gone to a protest or occupied the halls of Congress, it might be time for you to do just that. If you've never been arrested for this cause, now might be time for you to do that too. This moment calls for us to take extraordinary measures, and I and millions of people across America need each one of you in the fight with me. Thank you.
Thank you again, Jamila and Ben and Wendell. Courage takes many forms, and I hope we all heed your call to find even more courage than we've ever drawn up before. In the current environment, it is courageous to tell the truth. And an important element in all of what we're talking about is finding out what that truth is. An important part of making progress, of fighting back against bad things, is exposing what the bad things are and who is supporting it. Journalism plays a key role in keeping us informed, in speaking truth to power, and exposing wrongdoing, keeping policymakers honest. So I'd like to introduce our next segment and our next panelist, Julie Appleby. Many of us got to know and appreciate Julie's work as a journalist from her time at USA Today before joining KFF Health News. She has been reporting on healthcare issues for many years. She understands the policies, is familiar with the key groups in healthcare, and can thoroughly examine and precisely present the impacts of policies on beneficiaries. Help me in welcoming Julie to the stage.
Thank you for that lovely introduction. Yes, I've been asked to come here today and talk to you just a little bit about how reporters do their jobs. You know, what do we do all day up there? You know, because there's differences depending on the person, the outlet, the area they cover. I'm going to mainly focus on what I do as a health policy reporter at KFF Health News. So as David mentioned, KFF Health News is a national nonprofit newsroom that does in-depth journalism on health policy topics. Our stories run in outlets around the country. So from a little paper in North Dakota to the New York Times to NPR to a variety of things in between. I write about a variety of health policy related stories. You know, what's going on with the ACA, what's going on with the individual marketplace, employer coverage. We do a bill of the month feature you may have seen. We write about Medicare, Medicaid, et cetera. So that's our area of coverage. And at the outset, let me just say that it's my belief that no matter what their beat, every journalist's primary role is to provide information as objectively as possible, not to advocate for any particular cause. So in my view, the reading or viewing public decides what, if anything, to do with that information. So that said, let me just give you a little sort of like Reporter 101. How do reporters work? How, for example, do I come up with stories? So there's lots of ways that happens. So clearly, some are news-driven. A House committee, for example, drops a budget plan, or there's a proposed regulation concerning the Affordable Care Act. So we take a look at that. What's in it? What's going to happen? What do the experts think? What do real people think? How will it affect people? Some stories are editor-driven. They come up with an idea and assign it to a reporter. These are also often based on some kind of a news event that's happening. But most story ideas are generated by the reporters themselves. So how do we do that? I read widely. I try to read journals. I try to read other news outlets. I read policy papers. I read regulations, so you don't have to. I get a lot of emails. I probably get dozens of emails every day, and frankly, I don't read them all because I get too many, and many of them are completely unrelated to what I cover. I had a funny one the other day I was going to tell you about it. The subject line was, how to fix a flat butt without intense workouts. Well, that's not really something KFF Health News is going to cover, but thank you. Anyway, delete. So, but one of the main ways that I come up with story ideas is I keep in touch with the sources I've developed over the years. I check in with them every now and then and see what they're hearing because they're the ones that are out there. They know what's going on. These are experts who are actual people on the ground in the area that I cover. So it might be public health folks during a pandemic or researchers who study a topic or a disease or a policy area. Hospitals, insurance executives, advocacy groups, regulators, lawyers who follow health law, employers, who pay the bills, and yes, most importantly, real people who are affected by policies or situations or conditions. Sometimes people reach out to me. So like last year, for example, I got an email from a reader who was flummoxed by this tax bill for an Affordable Care Act plan that he'd never known he had. He was enrolled by a broker he'd never met in a state far from where he lived. That same week, I got another email, this one from a broker in another state, that detailed how he had lost hundreds of clients to rivals who were stealing his clients for the commissions. And I thought, wow, this is weird. Is it two one-offs, or is there something more going on here? Both of them had reached out to me because they had read earlier stories I had done that touched on the topic of Affordable Care Act in general. So I started calling some of my sources that I've developed over the years, talking to insurance agents around the country. Were they seeing this? And I kind of learned the problem was a little more widespread than had been revealed in the past or that federal regulators initially wanted to admit. So I ended up writing quite a few stories last year about people who were enrolled or switched in their Affordable Care Act plans without their express permission. So that's just one. Those are a variety of ways that reporters get ideas. So what's the process? So I'm going to try to talk with as many people as possible when I'm working on a story. They're not all going to get in my story because they have to be kept to like 1,000 or 1,200 words these days because stories are getting shorter. And it's actually much harder to write shorter than longer. I learned that at USA Today because we were all about short stories. But it's hard because you can't include every single thing. So I talk to a lot of folks. I write the stories. Once stories are done, they don't just automatically get posted. So instead, at KFF Health News and many other outlets, there's a rigorous process that we go through. So first, my editor reads the stories, a draft. She's an excellent editor, and she often has questions or has really good suggestions about, let's move this around, let's do that. I may have not written something as clearly as it could be. Maybe I've confused her. If I'm confusing my editor, I'm going to be confusing my readers. So we work on that. After the initial draft is satisfied, a second editor reads that story, and they may also have questions. Once those editors are satisfied, the story goes through another review. This time it's the copy desk, and they do another round of fact-checking. So many, many times during my career, the copy desk has saved me from myself finding a name I've misspelled, or a key word left out of a sentence, or a math error. So they've saved my butt on a number of occasions. So editors and copy editors then write the headlines generally, sometimes with input from me and sometimes not. So that's kind of like the day-to-day process. So as I mentioned, I get a lot of emails. I delete a lot of them. Let me just tell you a few things I appreciate about sources. If you're a source, what do I appreciate? I appreciate a source that gets back to me quickly because a lot of times I am on deadline. I strongly prefer on-the-record conversations, and most of my sources, we talk on the record. But that's not to say there's not a time when you can talk off the record. So what does that mean? What is on the record, off the record? And every reporter has perhaps a slightly different definition of that. So I would strongly encourage people, if you're going to be talking with reporters, to find out up front what does that mean to them. For me, off the record means that I am not going to use that information at all. I will not use that information in print or reporting unless I can get it confirmed and attributed elsewhere. The off-the-record person's name is not associated with that information. On background is another term that sometimes reporters use. For me, that means I can use the information but not attribute it to the person that I'm speaking with. I still have to confirm that information elsewhere, obviously. Other reporters may have differing definitions. So anonymous sources are also another topic. We at KFF Health News generally do not use anonymous sources. However, there are exceptions, such as when a person fears disclosing their identity will make them unsafe, or fear for their job or their families or political repercussions. In those cases, I need to get approval from my editor and the top editor in order to use an anonymous source. It may work differently at other news outlets. People often ask me, can they read my entire story before publication? And the answer is always no. That said, I will circle back with an individual if I'm quoting, that I'm quoting, if I have any question about what they said, or I want to double check a complex fact, say an intricate policy detail, or a portion of a lawsuit, or a scientific finding, just to make sure it's stated accurately. So it'll be that portion of the story, not the entire story. So kind of to wrap up, and then I want to take some questions. I'm going to leave a little bit of time for questions. So the sources I find myself returning to over and over are those who are honest about what they know. If they don't have an answer, they say so. They don't exaggerate. They can help me point me to source documents where I can get more information, public records, other places like that. Some help me find real people affected by the problems, and this is really important because reporters are always looking to show what does this policy or effect have on real people in the world. It can be hard to find people who want to talk on the record about their situation, but it's always helpful when they will. And finally, I do get a lot of emails. The ones that really catch my eye are generally to the point, and they explain why a particular idea is timely, why it fits my beat, and what information that they have that can help me with that story. So anyway, I hope that helps shed a little bit of light just on kind of what the day-to-day life is of a reporter, but I wanted to leave some time for questions, so I think Jeff or somebody had a microphone.
Yes.
And if you
Thank
wanted
you.
to see if anybody had any questions specifically.
Thank you so much, Julie. We can start right here.
My name is Morris Klein. How has AI affected your work?
Right now, I can't say AI has affected my work. I do get, I haven't seen it. I Google things too, and I get the little AI thing. But right now, AI is not writing my stories for me.
Thank you. Matt, can I check in with my colleague Matt for any online questions?
Sure. When there are constant updates and threats to healthcare occurring at such a rapid, relentless pace, how can we break through that noise to get coverage of an issue?
That's a very good question because there is a lot of noise and there's a lot of stuff happening right now. I think, like I was saying, when you have an idea, when there's an issue, when there's a topic, reporters are under this tremendous pressure, this daily deadline, this constant flow of news, constant emails. So the clearer and to the point your communications are with that reporter, that's helpful. Have a subject line that really spells out exactly what it is you're writing about or you're concerned about, your issue. I think another key point is to, if you can, know the outlets that you're talking with. Who is the reporter that covers the area that you are interested in at that news outlet? Again, go back to that email about the, fixing the flat butt. That is not what we cover. So who covers that? Where would you find that person? So that's do a little research ahead of time and try to do that. And yes, there's a lot of news out there. Not everything is going to get picked up.
Thank you. Okay, let's hear from Harry Ting, our friend Harry Ting.
Thanks. I have a question. Right now, we're dealing with a lot of false information that's spread by powerful entities, and how do we battle that when they have so much of a voice and or dominate the media? What do we do?
There is a lot of misinformation out there. I think the thing that people can do is turn to trusted news outlets and teach people what are trusted news outlets and how to figure out if something is real or not. It's an educational process. So I think that's the key, is to educate people about where you can check, is this true? How do we know it? Where are the source documents? How do you look it up? How would a reporter think about this? How good are their sources? Where are they sources? Does it sound too good to be true? It might be true. It might not be true. So that's a hard question to answer, but I think a lot of it just comes down to trying to educate people. How does journalism work? Where do you find trusted sources? What are they?
Thank you, Julie. I think we have to pause the questions for now, but we appreciate you tremendously.
Thank you for having me.
Good afternoon. I'm Toby Edelman. I'm a senior policy attorney in the D.C. office of the Center for Medicare Advocacy. I want to add my thanks to all of you for attending our summit this year, and I want to thank the sponsors of our litigation panel, AARP and SEIU, the Service Employees International Union. We at the Center work closely with both organizations and appreciate their tremendous advocacy and support over the years. Justice Sotomayor spoke at a Bar Association meeting last week. I think she was channeling Kathy Hurwitz. Justice Sotomayor said, quote, "We need trained and passionate and committed lawyers to fight this fight. Our job is to stand up for people who can't do it themselves. Right now, we can't lose the battles we are facing," close quote. In these tremendously challenging times, Justice Sotomayor challenged us. She challenged lawyers to fight for the people and issues we care about, to speak for those who need help in speaking up for themselves. And she challenged us not to give up, no matter what. Lawyers have stood up in these times, bringing case after case to stop the dismantling of our laws and institutions. Not all lawyers have answered Justice Sotomayor's call, of course, but the public interest legal community has. The public interest legal community, our lawyers, our paralegals, and our other advocates continue the fight. I'm delighted to be introducing our litigation panel today, whose 3 members represent the best of the brilliant and effective public interest bar in our field. Allie Bears is the Director of Litigation at the Center for Medicare Advocacy, Sarah Summers, Legal Director at the National Health Law Program, and Mami Jumphy, Senior Lead Attorney, AARP Foundation. Allie, I turn the panel over to you.
Good afternoon, and thank you, Toby. And I also want to say thank you, Toby, for what you have done for nursing home clients and nursing home residents. For nursing home residents in this country, you have transformed and protected the rights and dignity of nursing home facility residents for over 4 decades. So thank you, Toby. Good afternoon and welcome to our panel on advocacy in the courts. I am Allie Bears, the litigation director at the Center for Medicare Advocacy, and moderating today's panel, we will be exploring how strategic litigation can protect people's rights, expand access to justice, and dare I still say, drive systemic change. So our 2 panelists bring deep expertise and frontline experience in using the courts, not just as a forum for justice, but as a lever for advancing equity and reform. So first we have Sarah Summers, Legal Director at the National Health Law Program. Sarah and her colleagues at NHELP use litigation to challenge barriers in Medicaid and to protect the rights of everyone served by Medicaid. Which of course includes millions of people, and we know, thinking back to the very first slide we saw this morning, 12 million people, I believe, was the figure, who are dually eligible for both Medicaid and Medicare. And given current events, I also want to emphasize that NHELP, maybe not single-handedly, but almost single-handedly, prevented or halted the Trump administration's efforts to implement work requirements in Medicaid during the Trump administration's first term. Thank you, Sarah and NHELP, for that, and we'll be hearing some more about that. Also joining us is Mami Jumphy from AARP Foundation Litigation, where Mami is a senior attorney. And Mami and her colleagues litigate for older adults, and they tackle issues in healthcare, housing, employment, and civil rights. Mami's work ensures that older adults have a strong voice in the legal system and that systemic inequities are addressed head on. So thank you both for joining us and to talk about advocacy in the courts, and especially with regard to healthcare issues, and thinking also about how non-litigators might be able to participate in these issues. So Sarah, if I can start with you, if you can talk, and let's see if your slides are up, if we advance. There we go. Okay. So if you could talk to us about what are the legal theories that healthcare advocates should be aware of, and what are some key healthcare related cases and issues that we should be watching right now?
Thanks so much, Allie, and thanks to the Center for Medicare Advocacy for having this wonderful summit and inviting me. And I'm going to talk about two sort of big buckets of types of litigation. I'm going to talk in a very broad sense about administrative procedure, and then I'm going to hone in very sharply on Medicaid. So I'm going to start first talking about a case that, how many people have heard of this? Loper-Bright. And I just want to say, as an aside, it kind of blows my mind as someone who's spent, more than 25 years toiling in like the most hyper-technical, esoteric legal issues, to have this case have become such a talking point among mainstream journalists and even people who aren't that interested in law. But it did, in fact, have a big impact on Medicare, Medicaid, and a whole host of other programs. So let me take a step back. What this is about, and this phrase has been used at least once today, Chevron deference. And what this is about is the extent to which courts have to defer to a federal agency's interpretation of a statute. In particular, Loper-Bright was about, and Chevron were about federal regulations. I'm going to leave aside, this doesn't affect the world of Medicare, fair hearings, and the like. This is about regulations. And with Chevron had a test that had been in effect since the mid-1980s, which is when a court is trying to decide if you should defer to a regulation, did the statute directly address the issue? If no, if it's ambiguous or it doesn't, it's silent on your issue, then the courts defer to a permissible interpretation of the agency. This had been going along for 40 years without a lot of problems, but it's a real bugbear with the conservative bar and conservative judges and justices. And so finally the dominoes were kind of set up, and here comes a case out of, not Medicare, not Medicaid, not anything that impacts our day-to-day work, but it was about regulations governing commercial fishermen and the paying of observers on board. So again, a very hyper-specific issue, but it has massively broad implications because the court took the opportunity to overturn Chevron. And the quote from Justice Roberts' opinion is, it's unworkable. There's an eternal fog of uncertainty. I disagree, but I'm not the Chief Justice of the Supreme Court. So it's inconsistent with the Article 3 of the Constitution that gives power to courts to interpret statutes. And it's inconsistent with the Administrative Procedure Act, which doesn't direct courts to defer to agency interpretations to the same extent. So there was a lot of discussion about this before the case was heard and before it was decided, and a lot of very dire predictions. And I'm going to say, I think in the environmental area, that's kind of a whole different animal. But I will say, for now, in the Medicare, Medicaid area, it's not clear that this is going to be the cataclysm that people might have feared. And I'll tell you why. It's because courts actually were not afraid to not defer to the agency. Courts were perfectly happy to say, no, the statute says this and not that. No, you're wrong. No, we're not going to reach that issue. So it was worrisome, and what it is, the main threat I think it has opened up is so many lawsuits, so encouraging so many people to jump in there, encouraging big firms to reach out to their big clients and say, hey, remember how you hated this? Let's give it another try. Which leads to the next administrative law case. Again, from another part of the legal world that doesn't affect us. It was about fees charged to merchants for ATM transactions. And what this entity wanted to do was challenge a federal rule that had been finalized many years ago. There's a 6-year limit on that. 6 years after the rule has been finalized, that's the time period you have to challenge it. But not so. What the decision said is, as soon as you, an individual, an entity, are injured by it, then that's when the clock starts ticking. What this means is it's evergreen. This particular truck stop that was complaining about the ATM fees, that didn't exist back then. There's a lot of industry backing of this. It's not just the mom and pop truck stop that was interested in these fees. So this one, I think, actually is more of a sleeper and a little bit more concerning. And that we're already seeing, again, sort of the renewed interest in challenging things we thought was settled. And I'll just give you the third leg of this stool. I won't spend too much time on it, but this was about the Securities and Exchange Commission, which has long been a bugbear of the financial industry because they have the power to adjudicate fraud and other malfeasance in connection with securities trading and activities. And they didn't like that. And so what the result of this decision was that the court said this is actually like a trial, or this is like a suit at common law, so you need to give people a jury trial. That just totally defanged the SEC. It is a much bigger deal for a prosecutor to take something to trial than to do the internal SEC proceedings. So between the three of these things, we're all looking at a real new frontier in administrative law, coming to Medicare regulations, Medicaid regulations, and any number of federal regulations. So, again, it's still bubbling up there. About 6 months ago, I decided to write a fact sheet on how Loper Bright has affected Medicaid and Medicare, and it was a big ellipsis, TBD. So I'm going to go back and see what's happened in the next 6 months. So that's topic number one. And now I'm going to zoom way in on Medicaid. And let me just say, Loper Bright is, if you are facing it, litigators out there, we have fact sheets about how to deal with it in Medicaid and some theorizing, and we've been working with other public interest groups. So, reach out to us. But let's get to Medicaid. Has everyone heard of Medina versus Planned Parenthood of South Atlantic? Have anybody? Ooh, well, there you go. So, excited for new blood to hear about this exciting topic. Let me take a step back again. Since Medicaid was passed in the 1960s, individuals have gone to court and to argue that provisions of the Medicaid Act were violated. Eligibility rules, coverage rules, choice of provider rules, et cetera. And it wasn't until the 1980s when the court started getting more conservative and some of these theories were bubbling up, the question started to be raised, like, why do you have the right to go to court and enforce Medicaid? The Medicaid Act doesn't have anything in it that says you get to go to court and enforce these provisions. But that's always the way it's been. But in the 90s and into the 2000s, the court started to really narrow what you could enforce in Medicaid. And it has, when I started at NHELP, it was 2002, and a decision came out that freaked everybody out in the world of Medicaid enforcement. And it was looking like the end. We have managed to hold on for 25 years, and we're still holding on. And we're very excited about that. But here is the question that's presented. One of the things about this case, Medina, is that it's right there in the name. This is tied up in all the litigation around Planned Parenthood. There is a provision in the Medicaid Act that says any individual eligible for Medicaid can get assistance for any institution or person that's qualified who undertakes to provide them services. What happened was, after a lot of activism and sort of these sting videos against Planned Parenthood, many states tried to end Medicaid's participation in the Planned Parenthood's participation in Medicaid. Now, it's important to know there's a tiny sliver of abortions that are covered by Medicaid. It's just almost, it's a very, very narrow exception. But what Medicaid covers is family planning, basic services and supplies, basic, prenatal, postnatal, a variety of that area of health services. They get money. In many areas, there's not another provider around that can do that. And so this would be a huge blow to people who rely on Planned Parenthood for a lot of basic primary health care. So, but anyway, so this was one of the few areas in Medicaid where there was a division among the courts as to whether an individual could enforce it. And so there was a lot of cases that came up, and finally the Supreme Court has heard Medina. We have an explainer about it that I can share with Allie to share with others if they're interested. But we were worried because just a couple of years ago, in connection with the Nursing Home Reform Act, a case called Talevsky, which more of you may have heard about, said that the Medicaid's Nursing Home Reform Act was enforceable. And we thought if the Supreme Court finally talked about it, it might finally put it to bed. But no, it's reared its head again, and again, it's all tied up with the Planned Parenthood questions. The oral argument was April 2nd, and I read in Politico, Planned Parenthood's totally going to win. And I read in the Washington Post, Planned Parenthood's totally going to lose. So that gives you an idea of how the oral argument went. We don't know. We will see in June. But there is still potential for the Supreme Court to come back and say, actually, we're going to even further limit the extent to which individuals can enforce Medicaid. It is perhaps more likely that they might say a lot of Medicaid is enforceable, but not this part. And again, in trying to deal a blow to Planned Parenthood, it's going to have implications way beyond Planned Parenthood, way beyond family planning and sexual and reproductive health services. It could be any kind of provider. And because a lot of Medicaid beneficiaries are in a managed care world where it may not be as relevant, there's still plenty of areas where Medicaid beneficiaries and dual eligible beneficiaries need to be able to choose their provider. So watch the space. We'll see what happens.
I'm sorry to interrupt, but do you think the Talevsky holding would still stand even if the
It could, but we'll see. You know, we're hoping for the best, fearing the worst per usual. The last thing I will say is on work requirements. And I really want to say thank you, Allie, very kindly for the credit for the work requirements litigation. And I will say, indeed, my dear colleague, Jane Perkins, who's been at NHELP for 40 years, was the mastermind behind this theory. That said, we had excellent assistance from our friends at Jenner and Block, our friends at Munger Tolles, and those private law firms who helped us greatly. And we also, this may segue into a question you asked me later, we have partners among legal services and legal services-like organizations. Our co-counsel in these cases were the Tennessee Justice Center, Legal Services of Southeastern Missouri, Arkansas Legal Services, New Hampshire Legal Assistance. I'm probably forgetting other, Indiana Health Justice Center, but without them we wouldn't be able to do it. They have the connections to the clients and they give us the invaluable on-the-ground support in addition to doing all of the litigation in those cases. So work requirements, we were able to defeat them because it was a type of federal program where the administration approves an experiment or pilot project. And these work requirements were supposed to make you healthier because working makes you healthier. That was their theory. And we were able to argue that that was not a reasonable conclusion there. As we know, as we speak, who knows what's going on right this minute, but when I last checked, work requirements are still very much in the mix in reconciliation. It's, it's a huge fight. It has real traction with people who don't understand a lot about Medicaid or healthcare in general. And so if there is legislation, well then what we did wouldn't be possible because it's not, legislation is a whole different ballgame. That said, right now, legislation that they're proposing wouldn't take effect for several years. And so in the meantime, a whole bunch of states have these 1115 waivers poised to go. So watch this space, Every day you delay is a day saved. Anyway, I hope I didn't go over my time, but so that's it.
Great, thank you very much. And thank you. Mommy, if you could tell us a little bit about cases of importance to people who rely on Medicare and also put that in the context of litigation as a tool for activism and what non-litigators can do as well.
Okay, absolutely. So first of all, my name is Mommy like a mother. It's not that popular in the United States, but it's all the rage in Ghana, where my family originally comes from. So I would consider myself to be an activist / lawyer. So, I'm part of that do something crew that says, why aren't they doing something? Why aren't they doing something? They should be doing something. And so for me, advocacy in the courts is what doing something looks like. So today what I'm going to talk about very briefly is first, how can we use the law and courts to protect benefits and enforce rights? And let me just tell you, what you just heard Sarah say, she is absolutely so humble. What NHELP did with work requirements was literally life-changing, okay? And, when we watch the movie's a 2-hour movie, but what they don't tell you is how you have to find the plaintiffs. What they don't tell you is you have to find the law. What they don't tell you is everyone and their mama is calling you and saying, if you make bad law, it's going to... they don't tell you all that part, right? And then all of a sudden, the case is being, appealed, and it goes to the Supreme Court, okay? We don't say, we're in the Supreme Court, can't wait to see you, Sotomayor. What we say is, oh, wow, right? And then you hear people start talking, they say it's a 6-3 Supreme Court. It's a this Supreme Court. And you get very nervous, okay? And then you have to, when she was talking about, oh, yes, we work with these different groups and this, everyone has an opinion, it's not easy. So what they did literally changed lives, okay? Next thing is, I'm going to talk about some few Medicare and Medicaid cases that we should be watching, and then finally, how non-litigators can help. So let's first talk about the power of legal advocacy. So I'm a DC gal, I grew up in DC, and in general, folks mostly told us, we hate lawyers, right? We hate lawyers, there's too many lawyers, you bump into everyone in DC, it's a lawyer. But I can tell you one thing, and we saw with the past 100 days, issues came up, well, where's my lawyer? Where's my lawyer? We need some lawyers, and why? Because we have tools, right? I love my policy folks because what they're able to do is that evidence-based research that we can use as part of our briefs, okay? There are people like me who all you have to say is, hey, the baby is sick, and I'm like, I'm there and I agree with whatever you want. But there are other people who that doesn't work on them. And you need to show them evidence-based research about what you're trying to do. And so we love our policy folks, we love this. But I gotta tell you, when you tell me a problem, the first thing I respond is, who can we sue, okay? And part of the reason is because there's different pieces that we can use in the law. If something bad is happening, right, we can try and sue and get a preliminary injunction, okay, to stop it, to buy time. When Sarah was talking about, hey, this thing goes maybe be 6 years, you know, what will happen in between, right? To buy time, we can use a preliminary injunction. If the court issues a decision, we can appeal and try and get a stay. Again, buy time, right? Let's look at some of the things that happened between 2016 and 2020. We were able to stem the tide, right? So don't forget about us lawyers, because we're here, we want to sue, we want to help people out. People come to us when they are having their worst moment. Okay. They can't believe this happened. They come to us for their worst moment. And we want to help. And we have to find the best strategy possible to be able to help. Another tool that we have, in addition to us being able to sue, is we also can use amicus briefs, where we educate the court about how their ruling is going to impact, let's say, a population. Or sometimes we educate the court, hey, you think this law means one thing, but actually this law means something else. Or we educate the court, this is what Medicaid really is supposed to do. And so those amicus briefs, to me, are incredibly important, because actually, I don't even think them as only educating the court, but a lot of the press, remember how we had someone from the press here earlier? A lot of the press picked that up and are able to actually talk about what's happening. The last thing I would say is the other way we use law as a tool is also to come up with strategy, right? So when Sarah was talking about Loper Bright, well, guess what? What's good for the goose is good for the gander. If they're going to lose Loper Bright and say, hey, we're not ignoring all these agency regulations using Loper Bright, we need to too, right? And now that things are coming down, say, hey, let's sue under Loper Bright. We don't want them to be able to, like, defer to the agency. We want to be able to say this is wrong. So again, law, there's so many different pieces that work, right? You have going to Congress and your various representatives and advocating in front of them. You have going to the agencies and talking in front of them. But we also have the law, where people can sue and try their best to get justice. And that is what we do. We got a problem, who can we sue? So, first set of I chose these specific cases, 3 cases, because I wanted to show you times when people have been advocating for things for years, and they were able to get them right. And again, there's still litigation, but I really want to make sure people understand that when people say, hey, we're continuing to fight on this specific issue, we know that this issue is right, we know that it helps people, don't give up, because things can change. So for years, when I first started, people always said Medicare should be able to negotiate with drug companies, okay? And people were like, that's never going to happen, this and this. There was actually a special carve-out that the Medicare drug companies got that nobody else had, right? And that was actually the only way Medicare Part D actually got passed, okay? And what happened in the Inflation Reduction Act of 2022, they passed part of that law. Medicare can now negotiate prices with drug companies for certain drugs covered under Medicare Part D and Part B. This was a major victory, okay? One of the things when I'm going to talk today, I'm going to talk and kind of bring the people in the room. And so I just want you all to know, Why was this so important to people, right? Why was this so important to Medicare beneficiaries? Well, one of the things that happens that's great, again, with the policy folks, is they do all this research and they show us what people were actually living through in terms of the skyrocketing prices of drugs. And I know an AARP, Lee Purvis, has done a lot of work following the skyrocketing prices, right? But what I want to talk about is what the people were doing, okay? For many people, they couldn't afford the cost of their drugs, and so we would talk to people who the husband and wife would take turns taking medication. People would sell everything they own to purchase their drug. People would split their drug dosages in half, right? Some things would just absolutely forego getting their drugs filled. And then all of a sudden, they would say, again, I have Medicare Part D. I have this. How come this drug is so expensive? So again, with this law being passed, folks were like, hey, maybe we can get some kind of relief. And I do want to add, I'm specifically talking about the Medicare drug price negotiation, but do know the Inflation Reduction Act had so many other really good, strong prescription drug provisions. I'm just really focused on this one, because I'm talking about cases. Well, needless to say, the drug companies and trade associations were not having it. And they really launched a furious fight in several different federal district courts around the country, where they basically sued to stop the drug price negotiation program from going forward, alleging violations of the United States Constitution and the Administrative Procedure Act. One of the things that we did, again, law as a tool for social change, is we joined with Center for Medicare Advocacy, we joined with Justice and Aging, we joined with Medicare Rights Center, and wrote an amicus brief on behalf of older adults to really educate the court and the press and the public about why this law was so important, okay? And folks were thinking that, oh, by the way that they've kind of dispersed these cases, and of course they were strategically filed, we'll say, to certain districts, that, oh no, we were gonna get some bad rulings. But actually, to date, every court that has ruled on the merits has actually ruled in favor of the government and ruled in favor of the law being constitutional. We've gone through, I think, most of the district courts, and so now we're starting to get the rulings from the Circuit Court of Appeals, and we've got one recently from the Third Circuit, and in fact, they found that the law was constitutional. So stay tuned, let's keep on looking, but like I said, history made, and it's going on. And I will say, because this is a law, that's why they're going to the Constitution, the APA, but having said that, it's not so easy to erase. Next, we have the Federal Nursing Facility Staffing Rule. Again, history made. For the first time, CMS sets minimum staffing requirements, and specifically these requirements. First of all, having a registered nurse on staff 24/7, and secondly, the 3.48 hours of direct nursing care per resident per day. There are some exemptions to that. In addition, in terms of the actual implementation, I think it was like 2 years to 3 years. But I want to point out, this is history made, because this, again, were folks who, for decades, were pushing for this, okay? Charlene Harrington, decades pushing for this. Elizabeth Halifax, decades pushing for this. Toby Elderman, decades pushing for this. I mean, people were, Lori Spasteka, I mean, people were really doing research after research after research. I'm bringing the people back in to show the dangers of understaffing. So I'm going to share with you some of the dangers of understaffing. And again, remember I told you how when we hear a problem, who can we sue? So AARP Foundation has actually had several cases against nursing facility change, suing them directly for their understaffing. So what happens when you have understaffing? You don't have enough staff to be able to provide care to the residents, right? So what's the first thing? People don't get their meals, and you see a lot of people with weight loss and dehydration, okay? One person is helping someone move when it really should be 2 or 3, and they drop them, okay? You'll see people will not get moved at all, and so you'll see lots of wounds, pressure wounds. I mean, we have like a parade of horribles. Again, we're having a nice afternoon. I don't want to go through all of them, but some of them will have people will actually see their bone because they haven't been moved. Some of my cases, and in fact, we got reported in the news, where people are laying in their own feces for so long, the feces is coming out from the top of their shirt. I mean, things that you would not imagine, okay? And then we won't even add in what happened with the private equity coming in and buying the thing, okay? So this change in the rule, I really need to say, was life-changing. There had been some individual states that do have some kind of staffing rules, but this was a huge, huge change. Needless to say, the nursing facility industry was not having it. So there were 2 lawsuits that were filed, one in Texas, which is by the trade association and some local nursing facilities, and then another in Iowa. And the case that in Texas, again, Center for Medicare Advocacy and AARP also led amicus briefs there. Again, number one, educating about why actually they have the rule, what they need to do with the rule, and then secondly, talking about what people's experiences are when they do not have enough staff in these facilities. In Texas, I think in early April, the court ruled and actually vacated the nursing facility staffing rule. Then in the Iowa case, that one right now is still continuing, but we'll see exactly what happens. Oh, I should have said something before too. With regard to the Medicare drug price negotiation case, one of the things that happened was that when the administration changed, folks were saying like, oh, well, is this administration still gonna defend the rule? And a lot of people were thinking it's not. But actually the administration has continued to defend the Medicare drug price negotiation rule, okay? With regard to the federal nursing facility staffing rule, folks were wondering, is the administration still going to defend the rule? And in fact, to date, the administration still has defended the rule. Now, there is some talk that maybe that will change soon after this whole reconciliation thing is what we all, but I do want to say, one of the things I think is really important when we look at legal advocacy, we have to be very careful about assuming that, oh, just because this case was filed in a court, in a district where, oh, I just noticed that the judge that was appointed by either a Democrat or a Republican, I automatically know that that's how this person is going to rule. Now, there are definitely certain judges who you can tell how they're going to rule. Okay, so let's keep that clean. But to me, I always say, because we're about the issue, we are going to, number one, describe the issue the best we can. We're going to pick the best law we can to pursue it, right? And then if they disagree with us, we're going to appeal. So I don't feel that we have to approach these things with a defeatist attitude, like, oh, dang, I got to sign this kind of judge, it's over. No, what we need to do is figure out ways to put the best case forward to be able to win. Last case I want to talk to you about is Brown versus DC. So this is a case that my office brought on behalf of DC nursing facility residents. And it was under the ADA and the Olmstead, okay? And this is what happened. They would have a person who, let's just say, broke their leg, went to a hospital, and then went to the nursing facility, okay? And they were in the nursing facility for so long that they now needed to go back to the community, but they had no transition services or any way to go back to the community. And the way the case actually came to the attention of one of my colleagues was that she was going to the nursing facility and noticed all these people were walking around, and she was like, well, what are these people doing here? They actually didn't really need nursing, they needed nursing facility level of care, but the way they were thinking, they could be in the community, right? And so because of the integration mandate, which says that states and public entities must serve people in the most integrated settings possible, then we sued and said that that DC should actually provide transition assistance for these people with disabilities to be able to actually move in the community. And the reason why this is important is because we don't want to have a society where people are warehousing people with disabilities. If they actually have services in the community that can be used, right, and available, then we want people to be able to have the help that they need to get from the nursing facility to the community. So real quick, the federal court had a landmark ruling, and they said it is true that physically disabled nursing facility residents are some of the most vulnerable members of society who require meaningful assistance to effectuate their transition to the community. The district's Olmstead plan places too much burden of transitioning to the community on nursing facility residents themselves, thereby effectively transferring to them and the nursing facility staff the district's obligation to integrate persons with disabilities into community settings. And I'll give you an example. As you know, because most of the people that you get to the nursing facility, you lose your apartment, right? And so they didn't even have phones to call to see how they could get out. They had no idea where to even go, no one to even take them to look at an apartment. So that was one of the things that we sued for, to be able to get people to have. So now, quickly, what can non-litigators do? First of all, and I think it's a theme that we've been hearing throughout the day, be in the fight. Keep our eyes on the prize and our soul to the goal. Do not get discouraged, okay? I'm telling you and I'm pointing you out some of these cases because even though you see the case, these are things that people fought for a long time to get, and they got them. They got them. Next, part of being in the fight is doing your part. Submit comments to proposed rules when available. They're trying to take some of that away, right? But when you can't, make calls to representatives, and also support these advocacy organizations. Sometimes I don't have the time to be able to do all the different things I want to do, but if I see them send an email out that says, hey, let folks know we're having this thing on Medicaid, whatever, I'm like, okay, let me forward that to some people. Like, whatever tiny thing we can do to give support, let's do that. Next, agree to be plaintiffs or help find plaintiffs, okay? It's very difficult to find plaintiffs. You have a good issue, someone should sue, but it's hard to find plaintiffs. And let me tell you why. Plaintiffs are heroes, but like you notice when we said the case, that Brown case, it started in 2010. Okay, we got a decision December 31st, 2024. Think of all the people who were there. I know for me, again, because I work in AARP Foundation, a lot of our clients sometimes pass away before they even get their victory. But at the same time, these plaintiffs are the reasons why we're able to go forward. Next, share your story with media, social media, and the community. Policy staff, please continue to publish those reports. They are critical to us when we're trying to do our cases. And then let's make sure we communicate the information. And then finally, I say to everybody, self-care, rest if you must, but don't you dare quit.
Thank you. Thank you, Mommy. I really like hearing about the Brown case in particular, not only because of the amazing victory that AARP was able to get using Olmstead. Olmstead, for people who don't know, is that integration mandate that Mommy mentioned, but also because it actually started 1 year before the longest case that I've worked on, which is the observation status appeal rights case, which now those appeals now are finally happening, and people are able, some people who are placed on observation status in hospitals are able now finally to appeal for inpatient coverage of hospitalizations, which just, I think, goes to show that, yes, these cases, and particularly these reform cases, can take a very long time, but they are still worth doing. And I just want to make sure, do we have time for a couple of questions?
Unfortunately, we do have to cut it short to get back on time. You guys are absolutely wonderful. Thank you so much. Can we please give them a round of applause? We're pausing this conversation now, but please reach out to Mommy, Sarah. Thank you.
We are heading into another 15-minute break, so we will be regathering. When will that be, Jeff?
We're going to cut it short to 10, so we will be back at 3:30.
3:30. Thank you, everyone.
Wanting to do that forever. That's Judy's as we turn our attention to our oral health panel next, titled Mouths Matter in Medicare, I'd like to take a moment to thank another one of our 2025 CMA Summit panel sponsors, Santa Fe Group. We appreciate the long time and continued partnership between CMA and Santa Fe Group on the critical advocacy around expanding Medicare to include a comprehensive oral health benefit. We have an excellent panel here today to discuss the successes in this space and provide more insight on the advocacy work that continues. Moderating the panel, we have Dr. Dashanka Kleinman, Professor Emerita at the School of Public Health at University of Maryland and Vice President of Santa Fe Group. We will have presentations from Dr. Cheryl Baptiste-Hill, who is President of National Dental Association, and Dr. Lisa Simon, who is a dentist as well as a physician at Brigham and Women's Hospital and Harvard Medical School faculty. And with that, I will turn it over to Dr. Kleinman.
Well, thank you very much. We're delighted to be here and be able to join you all. It's been a fabulous meeting thus far, and we're looking forward to the rest of it as well. I wanted to just pause a little bit and just acknowledge the point and time in which we are at right now. This morning in the paper, we heard and learned about the FDA being asked to withdraw fluoride supplements by October of this year for children, and you've seen and heard the work that is going on to eliminate community water fluoridation, one of the 10 shining public health achievements of the last century. And so with that, I just wanted to give you some statistics. In 1958, 67% of 75-year-olds and older were edentulous. They had no teeth. And in 2024, that was 20%. The 1958 number is those that did not have access to fluoride or to certain access to care overall. And so that's our future if we aren't able to reverse or address some of the issues that are coming. So we want to thank you for having the opportunity here to talk about mouths matter and mouth matters in Medicare. And the work that we've been doing with all of you has really been a collective effort that has made a difference for all of us to come together. There's been the work under the Coalition for Medically Necessary Oral Health Care and a new coalition in oral health policy that has formed. And we are especially appreciative of the Center for Medicare Advocacy for the support and the tutelage that we've had with you for an extremely long time. I don't want to say, it's been probably over 20 years and more with Oral Health America, Santa Fe Group, and all the different organizations. So just to look back to 1965 when the Social Security Act amendment was passed, the explicit phrase that was used at that time was that they would exclude from Medicare coverage for services in connection with the care, treatment, filling, removal, and replacement of teeth or structures directly supporting the teeth. There's quite a bit of content in that phrase. And then the legislation authorizing the program provided a narrow exception that payment could be made for care that is, quote unquote, medically necessary. It was really a nondescript phrase that was used, and that has led to a lot of inconsistent interpretation by carriers and by advocates. So to extend the dental benefit into Medicare, a lot of work has been done in the area of research and education and providers, and I was just reflecting upon the fact that we were seeing the science that has been invested over these last 40, 50, now 60 years in July, and that has built on the evidence-based hope that we want to have and be able to carry that forward. But also, I was reflecting on the specialties of geriatrics and medicine, nursing, and dentistry, and the clinical capacity and education. And the demographics have changed. The way that we have worked in this area has been through legislative action, and we've benefited from the Partnership for Vision and Hearing and Dental. We have had movement in that area. We've had some challenges within our own profession, the dental profession, of how to proceed. And so we have not had successes in those. Those were attempts to get a much more comprehensive package. We've also most recently taken an advocacy approach when CMS opened the ruling that provides a regulatory pathway and the annual submission of nominations for a limited number of dental services that improve outcomes for those medical procedures that are covered by Medicare. And concurrently, as we've heard today, the incredible rise of the beneficiaries that are taking the option for a Medicare Advantage. So what we're going to learn today is we're going to tell you a little bit about where we are at this point in time and where we hope to go. But we're learning from some of this incremental approach some of the fragmentation that has occurred, and some of the issues that we need to continue to work on to ultimately get our goal of comprehensive health care. So Cheryl, please take it away.
Thank you. Can you hear me okay? I can hear you great. Okay, my name's Cheryl Batiste. I'm a native Washingtonian. My father's from Grenada in the West Indies. But I always tell people my father raised me knowing what tyranny was. When I got to school, I knew because he had a tea bag that hung on the knob of the radio that said taxation without representation. Washington, D.C., I just have to hit that home because people don't realize we're not a state. So our budget is determined by Congress. Right now we're fighting because of our Medicaid funding. So my father also said if you're not part of the solution, you're part of the problem. So I have to make sure I'm here. He started the first dental benefits for the District of Columbia workers from AFGE and AFSCME. So it's something that's in my DNA. I want to make sure that we are included in the rest of the body because we're always separate from the rest of the body. So thank you so much. I'm going to put there we go. And I want to make sure that you get my phone number because I do want to talk to you. You all, this has been wonderful. I've never been part of policy, so this has been a fabulous morning of learning for me. So I want to make sure you know that when you look at inflammation, inflammation affects the rest of the body. So your mouth has more blood vessels in it than any other part of your body. Your mouth has more microbes like bacteria, fungus, viruses than any other part of your body. So people think when we say the gateway to the rest of the body, we're talking because you're eating through it. No, it's because those microorganisms get into the bloodstream. They cause inflammation in the body, and that affects every single organ. So we want to make sure that you know that the mouth doesn't come to the office by itself, that the mouth is part of the body, and there are consequences from having that inflammation. Your teeth sit in bone. The bone is a matrix all around, and then you have gum tissue. Gum can only attach to the bone. It doesn't attach to the tooth. So there's always a space between your gum tissue and your tooth. And the bad bugs get down inside of that, and that's what swim around in your body. So we want to make sure that you know there is a connection. And when I say these different things that you hear, heart disease, circulatory diseases, strokes, diabetes, pregnancy complications, meaning low birth weight, you are inhaling, so you get infections from the mouth that go into your lungs. For arthritis, is that inflammation? So you want to make sure that you study these things and know that Alzheimer's disease, they're now trying to say is a type of diabetes that's in the brain. So there is definitely a connection for all of that. And I want to make sure I just stay on my topic because I'll start wandering here. So we're physicians of the oral cavity, and people don't see that. They think we're just filling some teeth and making people look glamorous by whitening or bleaching or putting some veneers on, but it's more to that. So when you look at oral cancer, there's so much effect from the mouth. You have the HPV viruses, you have different modalities that people are relating with each other. So it's different organisms that are in other parts of the body, and then from the mouth, you're getting those types of infections in other parts of your body. So I want to make sure that you're clear that all this isn't just a line just in your mouth. If you look at missing teeth and you look at people who they are crooked, if you have crooked teeth, the teeth that are inside, they're going to have a lot more gum tissue and no bone tissue on them. So when we say you might need to have your teeth corrected for the position with ortho or Invisalign, that also helps the health of the rest of your body. So it's not just something that's aesthetic so that when you smile, all the teeth are in alignment. And that also affects your posture too. The way your joint and your muscles are connected here, it's all connection, and we need to make sure that we are part of the rest of the body. It also affects your self-esteem, your ability to chew, to eat. So all these other issues are something that we need to make sure that you all are aware of. You want to protect all the rest of your body. The sickle cell disease, and I might have already skipped over that one. With sickle cell disease, if you get a cavity and you have sickle cell trait or disease, you get bacteria and inflammation inside of the tooth or inside of the gum that can cause you to have to go to the hospital. A lot of things can lead to death, and as well as the hospitalization. So when you look at your mouth, it mirrors what's going on in the rest of your body. We can also find a lot of disease. Excuse me, my mouth is getting cotton. As oral physicians, we can find a lot of diseases that people might not have already had diagnosed because they might not have seen the physician, or the physicians didn't ask enough questions. If I look underneath the tongue and I see, when you talk about varicose veins, I know you have something going on with your blood pressure. So there are all kinds of signs, obstructive sleep apnea. We can look at the indentation or scalloping of the tongue. So much goes on in the body. And this one is just something I just added in here, but I just wanted to let you see some science in there about the mouth. And I wanted to make sure you know that dental disease is the most common disease on the planet. 60% of your military evacuations due to medical issues come from a dental issue. You can be denied in the military because of obesity or mental problems or dental problems. And children miss about 34 million hours of school annually due to dental pain. Out-of-pocket spending is a lot more for dental than it is for medical. So a lot of people stay away or they avoid going to the dentist because of that. Dental problems are something that are $46 million annually could have been prevented from having to been spent by treating the dental diseases in the very beginning. So I was told that I have 5 minutes, and I'm there at that. So.
Do you want to just do this slide? And then
I thought we were going to ask the questions there. So with the Build Back Better Act, we know that we got coverage. Medicare does not have a dental benefit. You have to get a rider or a separate coverage. A lot of people don't know that. And when they are at the point of having to have Medicare, it's a $1,000 or $2,000 annual maximum, which might not seem like it's a little amount to you, or might seem like a lot, but it's a small amount for us, because if you're looking at getting a denture, not a set, but just one arch, you're looking at $2,000. So if I need to get a top and bottom, I need $4,000. It's not going to help me to have that $1,000 or $2,000 annual maximum. So we really need to make sure that we have somebody who is a dentist who can go on the panels for Medicare, because our claim submission is much different than a medical. We're not billing for an encounter. We don't get paid by the encounter. And every time we have a patient come in, I'm going to need to take an hour or an hour and a half. I don't have 15 minutes because I'm actually going to be doing a surgical procedure. I have to anesthetize. I have to go through a whole set of your history. I need to go in there, and whatever I remove, I have to replace. And I say now, I retired earlier this year, but if I was still in practice, and I retired because I couldn't afford to do it any longer. 80% of our patients were DC Medicaid. If I'm getting $40 for a filling and it's costing me $450 every hour to keep my doors open, the math doesn't add up. So that's one thing, the reason why I'm there. And people don't go to see the dentist when they don't have the money to go see the dentist. They put it off, or they just say, I'm going to avoid going, period. Malpractice insurance premiums are higher for those of us who accept Medicaid and Medicare in the dental practice. So I'm getting paid less, but I have to pay more for my coverage. We make sure that there's a process called recruitment. So if they see that I've done more fillings on a certain surface of a tooth than somebody else in my area, they go back and they take a look. And some of the times they want to have money recouped. Well, I already did the work at a reduced rate, and now you're going to take it back from me again? The patient got the benefit, they got to go home with it. Or they'll say they don't cover something. If anyone had a root canal before, you had to have your tooth built up after the root canal, and sometimes you might have to have a post put in. Well, Medicaid said, well, we're not covering that post. So when you call up, they say, well, just bill it like a filling, because it is a filling. The filling is around it, but the post was just there to strengthen it. But then when they go back and they do the audit of your charts, they say, oh, well, you did a post. Yeah, post we gave away, we billed for a filling. We get paid more for the post than we did for a filling, and then they come back and do that recoupment.
Dr. Baptiste, can we move
Yes,
on
go
to
ahead.
Dr. Simon? But thank you so very much. Thank you.
I'm going to keep on going.
Thank you. Do you have more? Sorry, I'll just click through till my slides come. Thanks so much. Thank you all so much for having me here. I've been tasked with trying to describe the entire history of Medicare and where we are now in 5 minutes, and so we'll see how well I do. Luckily, I have amazing introductions, and you know all the context now, and hopefully this resonates, especially with those of you who are MA detractors in the audience. Allow me to provide some additional ammo for you. So as Dr. Kleinman already mentioned, the lawyers did a very good job in 1965 and came up with every possible context for which we could treat teeth, and then barred it within the Social Security Act of 1965. Without an act of Congress, this will not change, and Medicare will not be able to provide a dental benefit. This is where we are. What does it actually cause? So this is a study we did that looks at the rates of people reporting they're missing all of their teeth, or a complete edentulosum in dentist speak. The only thing I want you to make note of here is the giant jump that occurs right at 65. The thing that I think is most important to see about this is that if you look at almost any other health outcome, the opposite of this occurs. Medicare, as the closest thing to universal health insurance we have, decreases racial inequities in health outcomes, it increases access to preventative services, it increases patient self-reported care. But when you look at dentistry, the exact opposite occurs, and we see a 5 percentage point jump in complete edentulism. This is a measurable harm because Medicare doesn't cover dental care. People have mentioned repeatedly today, actually, that one of the very appealing benefits of the Medicare Advantage plan is a dental benefit. But when you actually look at the rates of dental utilization in Medicare Advantage versus traditional Medicare, it's a complete wash. Utilization remains low, and out-of-pocket expenses remain extremely high, higher, as Dr. Baptiste Hill said, than almost any other medical service among both MA and TM beneficiaries. And in fact, we have a study that showed that while about more than 98% of Medicare Advantage plans report offering a dental benefit, when we applied what I would consider not even a bare minimum of quality, but sort of what we might expect from a middling private dental plan, only about 4% of Medicare Advantage plans met our quality metric. So here's the map of every county and the number of Medicare Advantage dental plans that are available to beneficiaries. And here's the same map if you only look at high quality dental plans. And I want to emphasize that high quality doesn't really mean that. Here's the most recent change. We're going to pivot to sort of traditional Medicare briefly with a circle back to Medicare Advantage. So we know we can't cover a dental benefit, except using this absolutely brilliant, pioneering language produced by Centers for Medicare Advocacy in part in 2023. Starting in 2023, the Centers for Medicare and Medicaid Services produced this amazing clarification of existing policy. I'll come back to why that's important. That said that if a dental procedure was inextricably linked to a medical outcome, it could be covered. In essence, when is dental care no longer dental care? When it's inextricably linked to a medical procedure and then Medicare can cover it. The most amazing thing is that this also included a comment period, which has allowed every subsequent year since 2023 an expansion of the types of diagnoses and treatments that are covered under this benefit. So you can see the entire list here. I'll note that this is a slide that I totally cribbed from CMA and does not include the more recent people that starting in January 1st, 2025, people with renal disease undergoing dialysis are also eligible, a huge portion of the Medicare population. We have some estimates. This is using numbers from the Medicare Current Beneficiary Survey, if anyone's a numbers wonk. And we find that this is actually only traditional Medicare. 1.2 million Medicare beneficiaries are newly eligible for dental care through Medicare as a result of this policy, or rather, codification of existing policy, meaning it cannot be or it cannot easily be redacted by the current administration, which is why this is so incredible. You can more or less double this number for a back of the envelope calculation because these policies apply to Medicare Advantage programs as well. And then I'll end on a downer note because that seems like the right thing to do too. This is an amazing policy. I am so excited about it. But we also have work in progress that shows that without participation of dental providers, we're not going to see access to care for these 1.2 or 2.4 million people. So this is looking at the number of dentists who participate in Medicare, and you can see that there is a measurable drop, around 15%, starting right when this policy rolled out. So we have some work to do to bring our whole profession on board to actually help people and deliver the promise of Medicare dental benefit. Thanks, everyone.
Do we have time for a few questions? I mean, is that all right? So, Lisa, at the very last slide, you said we have a problem within our own profession and in terms of getting the dentists to be enrolled in Medicare and in Medicaid, let me just say, because we were talking about Medicaid earlier. Both of you, what are some of the answers there? How can we make a difference in that area?
Well, I want to thank Dr. Baptiste for also being honest about the fact that when we talk about how providers should step up, there are genuine financial hurdles for the vast majority of dentists who are in private practice to participate in this program. So things like reimbursement rates can make a difference. But to a certain extent, I think this is a matter of awareness and culture. Dentistry is sort of inherently more entrepreneurial than a lot of medicine. The average dentist is self-employed and operates in a solo private practice. I'm a primary care provider. I work for a hospital. I have never enrolled in Medicare. I have never billed to Medicare. I have never billed to Medicaid. But I can take care of patients with Medicare and Medicaid because I work in a system that essentially does that for me. So I think a lot of this is about friction. You have to make it easy. And some of that is happening. So even though this policy started in January 2023, the digital billing software or online platform for Medicare dental billing didn't come online until July 2024. So probably hopefully we might see some improvements in dentist participation, starting with making things easier for them to actually bill for the services they provide. The other thing I'd mention is that I love giving this talk to physicians because I end up talking to a bunch of oncologists and cardiac surgeons and primary care providers who had no idea this was available and want to connect their patients to care. So the other piece is we have a broader community that needs to know about it too.
Exactly.
Anything you want to add?
Well, they told me that the Medicaid fee schedule is based on Medicare. So I said, well, how do you base a dental fee schedule on Medicare when there is no Medicare coverage? And they looked at me like, our fee schedule has not increased since 2007. 2007, but our prices have gone up like this. So helping that would be the major thing for getting enrollment or engagement.
So in addition, the Consortium for Medically Necessary Oral Health Coverage did have a poll last month and asked 1,000 registered adult voters ages 65 and older a few questions, one of which addressed that, do they know that traditional Medicare does not include dental? And of course, the majority of them did. That's good. Bad news, but good that they knew. But most voters were not aware of the current opportunity for Medicare to offer dental services for set conditions. So I think that there's another option for us. The public itself needs to know where we are so that they themselves could ask their providers and ask others and their legislators for additional support. So I'd like to thank both of you for your comments and your thoughts on this, and I want to thank the Center for Medicare Advocacy again. And I want to use a quote that actually Dr. Simon had in one of her papers. I'm blending your quote. The quote is, "The notion of dentistry as a field separate from medicine is a historical phenomenon, not a biologic or clinical fact, and that this division places an undue burden of dental disease on the most vulnerable Americans who face barriers to accessing dental care." So we have our work cut out for us, and we're just pleased to be able to work with all of you towards the same end. Thank you.
Hello, everyone. Before introducing the next section, I'd like to take a moment to thank our 2025 Friends of the Summit. This is going to be fun. the American Medical Rehabilitation Providers Association. I'd like to thank our friends at Gerontological Society of America and the Legal Action Center, our friends at the National Academy of Social Insurance, the National Committee to Preserve Social Security and Medicare, along with our friends in Massachusetts, Margolis, Bloom, and D'Agostino, and our friends in Florida, McCarthy, Summers, Wood, Norman, Melby, and Schultz, attorneys at law. Nailed it. All right. At this time, I'd like to introduce the Elder Law Perspective section of the afternoon. Jerry Rothkopf, who is the founder and managing attorney of Rothkopf Law Group, which serves New Jersey and Pennsylvania, a longtime friend of the center and partner. Please help me to welcome to the stage the great and powerful Jerry Rothkopf.
All right, well, is it winding down? So thank you for inviting me, and good afternoon, all. I'm Jerry Rothkopf. Well, if I learned nothing from this afternoon, and I learned a lot, I'd better start flossing more, if nothing else, don't you think? So, excellent presentation. So, as was said, I'm Jerry Rothkopf. I'm managing attorney of Rothkopf Law Group. I'm not here to discuss substantive issues, and David, and disappointing, I do not have slides as a result of that. And I'm going to leave the substantive issues to you as the public health experts in this room. But what I'd like to discuss this afternoon is what impact you have, the center, CMA itself, and what all of you do in your advocacy fields, and what impact it has on elder law attorneys and the practice of elder law, and more importantly, our clients. Virtually all of you are involved in academia, public service, nonprofits, or government advocacy. I am one of the few private attorneys here today. So why am I here? And I've been here since almost the first CMA Summit. First off, for self-serving reasons, if nothing else. You see, I have twin boys and who went to school in D.C., GW and American respectively. And one son, who's right here, Evan, will be graduating from Georgetown Law School this weekend. So an excuse to come to D.C. to see my family. And Evan will be, and coincidentally, and maybe apropos for this audience, he will be involved in public health law and starting at the law firm D.C. office of Latham and Watkins. So, and we are very proud of him. Secondly, I so admire what you do. When I'm hearing the powerful presentations, it makes me, as an elder law attorney, just want to basically run right through the Medicare wall, brick wall, really. So thank you for what you do to improve the lives of older adults and those with disabilities on a daily basis. In fact, secretively, I think I want to be you, and that's another reason why I am here, to help in the good fight. Then reality sets in. I'm managing attorney of a 50-plus staff law firm with working in 2 states with 7 offices. So it's my way of living, I think, vicariously through you. So thank you for what you do. But beyond my own family endeavors and my own fantasy, I am here to support CMA because I owe in part my start of my own elder law career to CMA. You see, 25 years ago, 1 year before he was born, I decided to switch my career from personal injury law, and I was doing a little nursing home litigation, to elder care law. A major reason was a NAILA conference that I attended in Philadelphia. I think it was in May of '99 or 2000, something like that, which conveniently was a few blocks from my office, and I knew it well because it's where in 1981 I had my bar mitzvah reception at the Work Hotel in Philly. So why not? I knew the place well. So what I didn't realize then, within 2 hours I was hooked to work to advocacy for older adults. And I became energized in a way that eluded me the first several years of my practice. I became energized in part due to a speech I heard about government advocacy and the importance of government advocacy. And yes, if you're thinking the speech was by Judy Stein, you're correct. Who I think you were, Judy, I think you were installed as the NAILA president right around then, or incoming, or something along those lines. So upon returning home that evening, I advised my wife I wanted to practice elder care law. 2 months later, I opened my own elder care law firm. And then Evan was born a year later. Beyond that conference in the early 2000s, CMA helped me with a Medicare case I had, which maybe sounds familiar to some of you back in 2001, 2002. It involved a woman who suffered from COPD. Medicare denied her a procedure called lung volume reduction surgery. And apparently at that time, in order for Medicare to cover the complicated surgery, the patient must have enrolled in a national trial program. I think it was called the NET program, National Emphysema Treatment Trial, or NET. At the time, believe it was Medicare's first national trial program of its kind. Once enrolled in the program, half the patients received surgery, the other half were randomized for continued therapy, which in essence was a death sentence. My client was randomized to therapy, and therefore Medicare would not cover the cost of the approximate $50,000 surgery at that time. And unfortunately, she did not have the financial means to cover the surgery herself, and therefore, by the time they came to me, we were at the ALJ level. And without really knowing what I was doing. So we had, of course, claimed lung volume reduction surgery was not an experimental medical procedure, and therefore should be a covered procedure. But how in the world can I prove the procedure was reasonable and necessary? Up stepped CMA. I called CMA. I spoke to a very helpful person, but honestly, I don't recall who I spoke with. However, after explaining the issue, I was given the name of a person who had a similar issue and was dealing with a family member. I was given a daughter of a family member. Through my original contact with CMA, I learned of a world-renowned physician who was practicing medicine in St. Louis at Washington University. A world-renowned surgeon by the name of Dr. Joel Cooper. He pioneered lung volume reduction surgery. By the way, Dr. Cooper did not only pioneer lung volume reduction surgery, but also was known for having completed the first successful lung transplant and first successful double lung transplant in the United States. So I gave him a call. He actually took my call, believe it or not, and he was my client's only chance at surgery, since every other major hospital system, including those in the Philadelphia area, were involved in the NET trial program, so they couldn't perform surgery outside the NET program. To my astonishment, Dr. Cooper volunteered to attend and testify at the ALJ hearing in person. All he wanted was his travel costs covered. Well, he had his own agenda, but that was okay, meaning that he soon came to the University of Pennsylvania hospital system, so he's probably there on business, and he had his own agenda because he needed to make money doing lung volume reduction surgery. Needless to say, we won the ALJ hearing. I can still see the look of startlement on the face of the ALJ, wondering how in the world I was able to have this renowned surgeon come to Philly and testify in person. There were no words to express the gratification I felt that I was able to help this woman. My work and advocacy felt meaningful, and it still feels meaningful today. Therefore, I learned early on in my elder law career the value of Medicare advocacy, particularly the fact that elder care goes far beyond estate planning, guardianships, Medicaid planning, protecting assets from the nursing home. What CMA and all of you do does matter, and it has lasting impact on elder law attorneys and clients throughout the U.S. Yes, I do wish more elder care attorneys were present today, and more would see the value of engaging in Medicare advocacy services. However, elder care attorneys do benefit from CMA services. I'm going to give you a few examples how. Several thousand elder law attorneys throughout the U.S. are regularly having discussions with their clients and their caregivers regarding the impact of the GMO case and how to extend Medicare-covered days in the nursing home to maximize therapy, and as well as access additional home care coverage, and if necessary, referring them to the CMA website for the GMO self-help appeal guide. Thanks to CMA, several thousand elder law attorneys regularly advise their clients on observation status and how to appeal their placement on observation status in hospitals, and once again, refer them to the CMA toolkit on the appeal process. CMA's weekly email alerts are regularly disseminated across dozens of elder law listservs nationwide, keeping elder law practitioners informed as to the latest Medicare issues impacting their practice and clients. Thanks to CMA, elder law attorneys counsel their clients regarding the pros and cons of Medicare Advantage plans versus traditional Medicare, as was discussed today. And CMA's Medicare handbook, which I was the pleasure of receiving a complimentary copy last year, if I recall, is the Medicare Bible for elder law attorneys. If there's a perplexing Medicare issue, elder law attorneys turn to the Medicare handbook for the answer. And like myself over 25 years ago, elder law attorneys from across the U.S. regularly contact and rely upon CMA for advice on Medicare issues. Therefore, what you do does matter. The elder law bar needs you. We rely upon you. Elder law attorneys need more Judy Steins, not just more Judy Steins, but people like, and I didn't see Charlie Sabatino. He's on, God bless him for that. So people like Charlie Sabatino, and my colleagues are here. Harry Margolis over there, Morris Klein over there, and thank you for being here. And you'll soon, I think, going to hear from Frank Johns as well. People who see elder law beyond estate and asset protection planning. So thank you, Judy, Charlie, Frank, Morris, and for setting such a fine example of what an elder law attorney should be. And lastly, since I am from New Jersey, I'm going to quote a famous poet. It's not Walt Whitman, which I cross that bridge regularly. Of course, it's going to be Bruce Springsteen. So when Springsteen was inducted, and I was present, myself and my daughters were there in Brooklyn, when he inducted the E Street Band into the Rock and Roll Hall of Fame. He was there as a solo artist already. He said this, the story you tell together is much more powerful than anyone can do on their own. So with that, it's a partnership. We need CMA, we need all of you to do our jobs and disseminate that information for the clients. So thank you for all you do. Have a wonderful rest of the afternoon.
Thank you, Jerry, and the respect is mutual. We need elder law attorneys, and we need more of them. The work is different and equally vital. As we enter, thank you for all of your patience and your endurance. But as we enter the last section of this year's summit, I'd like to welcome up to the stage my co-director, Scott, who's already here, my current boss and board chair, Judy Fader, and I'm missing somebody.
There's another Judy.
Oh, my former boss, CMA founder and senior advisor, Judy Stein. Thanks, Scott. We're going to introduce the video, right? Yeah.
First, I'd like to take a moment and thank our Senator John A. Rockefeller Lecture sponsor, the John A. Hartford Foundation. Thank you so much for your long time support, guidance, and partnership. Judy Stein has been and continues to be, and God hope will continue to be, to me and many others, an inspiration and a model, a mentor. At this point, I would like to go ahead and play a video from Frank Johns, who's one more person who's been impacted by Judy and her life work. Frank Johns is a principal partner at Booth, Harrington & Johns, North Carolina's first elder law firm. He is a former CMA board member and, like Judy, former president of the National Academy of Elder Law Attorneys. We are ready for his video.
Greetings to the Center for Medicare Advocacy community and to you, dear Judy. You know, Judy, there's one thing among many on which we can agree. Time has raced by, accelerating at breakneck speed. You know, luckily, I'm an example of the research that concludes that long-term memory is the last to go. If my long-term memory serves me well, my earliest recollection of you was at the Joint Conference of Law and Aging in 1989, at a time when your founding of the Center for Medicare Advocacy was in its infancy. You know, from there, our relationship was seated in mutual respect that we had for each other, sprouted into lasting friendship in the early 90s as members of the NALA Board of Directors, and it flowered in full bloom in the late 90s as we accepted NALA leadership positions. You may remember that in your acceptance remarks as NALA president, you used your love of tending to your garden as a metaphor for your duties, tending to the growth of NALA as it sprouted, assuring that it would flower in full bloom. A few years passed. Becky Morgan became NALA president in 88, 90. You became president in 2000, 2001. And my time as president in 99, 2000, sandwiched between you and Becky, was nothing short of a godsend. I was a recipient of the support, guidance, and friendship of Becky and you that helped me through that year without making too many big mistakes. You know, in the early 2000, I was honored to serve on the CMA board. And in the years since, although time and distance have limited contact, we've surely remained connected. In both organizations, NALA and CMA, you've exercised your commitment to applying policies and procedures that kept each group accountable and respected. I can still remember in a NALA board meeting in Tucson, Arizona, where you declared that you were pleased to accept the title of Process Maven. I'm sure you've continued to carry that title at CMA to this day, or at least to the day of your retirement. Going back to 1995, I bet you remember, I know I'll never forget, when Vincent Rousseau announced the first Teresa Award given to our dear friend and colleague, Ira Wiesner. As Vincent shared the life of his daughter, Teresa, and the life of Ira's son, Justin, I stood there with you on my right and Myra Gilfix on my left, embraced as we teared up in the emotion of that moment. A year later, I was honored to be awarded the Teresa Award, and my comments described us as kindred spirits. Not surprisingly, you were awarded the Teresa Award in 2004 for your unwavering commitment, dedication, and advocacy for the millions of Medicare recipients to whom you and CMA gave and continue to give voice. We are forever kindred spirits. You were a visionary for so many years, having seen the need for CMA where advocacy would be organized to serve Medicare recipients individually and to litigate for a class of those Medicare recipients, countless federal cases, many of which not only did you win, but you had the courts declaring precedent decisions. CMA continues to grow and be recognized as a leader in the continuing fight for the Medicare benefits that are entitlements for the millions of older Americans receiving them. Judy, CMA is your impressive legacy, seeding, sprouting, and tending to it as it flowered. It surely will be the gift that keeps on giving and will continue for years beyond our lives. I'm so grateful, Judy, to have you as a part of my life. Your kindness and compassion have enriched me, as it has so many others fortunate enough to have crossed your path on life's journey. Ann and I wish we could be there to celebrate and be a part of the reception that honors you. Surely we're there as kindred spirits. Judy, I remain your kindred spirits, and congratulations on another successful summit. I look forward to seeing you in the future.
It is my privilege today to introduce our John D., or J. Rockefeller, he preferred, lecturer, and it's Judy Stein. it is hard to follow that as a tribute. But what I'm going to say is I think that all of us come here every year, and we'll keep on coming, in order to reignite, if you can do what I'm about to say, it's a bit of a mixed metaphor, reignite our North Star. Can we accept that? Okay, that's good, thank you, it's good. And I looked up what a North Star is. I Googled what it is. It's a guiding light that gives us direction, inspiration, and sense of purpose. And our J. Rockefeller lecturer today, Judy Stein, has built a career as a North Star. You are an inspiration and a star. You have always, Judy, been a woman with a mission. And you've built an organization that pursues with gusto and efficacy that mission for all of us, because there are a lot of Medicare beneficiaries in this room, never mind, and in this audience, I expect. And you inspire us to come together as a community to keep on keeping on in good times and much less good times. So it is my honor to present you, North Star, with your award as our J. Rockefeller lecturer. Look around. And now the podium is yours, and we look forward to learning from you as always.
Many themes have been already spoken about, but I'm going to repeat some of them because they are appropriate for the moment. Before I do that, I do want to thank so many of you who are longtime friends. Jerry, for your beautiful remarks. Ben Belton, for your smile and steadfastness. It's too many names for me to say, but I do have to say, my daughter's here, surprised me from Atlanta today. And I looked up and I thought, oh, she looks familiar. And my husband, Ken Dardick, thank you. Today I celebrate, not necessarily where we are in history, but the history of advocacy and of the Center for Medicare Advocacy, which was started in 1986 because I went to law school to join legal services. And in about 1984 and 85, the Reagan administration determined that entities that received legal services funding could no longer do systemic change work. I always analogize that, Kate, who's a nurse, to that someone came in if they had a cut and it looked a little nasty, that you could clean it and put a Band-Aid on it. But damn, if the 15th kid came into your office, she's a school nurse, and it looked another cut and it looked kind of nasty, and you thought, maybe there's something in the, let's just say, water, and we need to find out what the real problem is and address that problem while we do take care of each individual. The overall problem was no longer allowed to be solved by legal services attorneys. And I went to law school to join legal services to change the world for each individual, and then having spotted an issue that was affecting too many, to try and change that too. So I regretfully left legal services, as did a number of my other colleagues. Many left legal services. Many others created other pathways to do legal justice work. And I would like to also point out that the first president of the Center for Medicare Advocacy and my neighbor who saw me through some very dark times, including that I had young kids at that time, Marion Platt is also here, Marion. Here we are today as the Center for Medicare Advocacy is approaching its 40th anniversary, and Medicare is approaching its 60th anniversary. I have long felt that part of my job as a founder and as a leader was to pass the baton so that the Center for Medicare Advocacy could exist into the future, recognizing that, like everyone else, I'm not immortal. And I have had, with our board of directors, Judy as chair, we developed a 5-year transition and guiding light plan, which included finding, recognizing leadership, moving the directorship from the founder, which is important, and finding a lot more money. Well, we've succeeded at the first part of that mission. I think it's wonderful that the center has been able to elevate such esteemed folks as our co-directors now, David Lipschitz for Law and Policy, and Scott Perkins for Operations and Management. Looking within and knowing that they are part of the culture of the organization and dedicated to it, and they are a fabulous partnership, and mostly get along with, Scott gets along with David, mostly. Like you, Tricia. Also, it allowed us in a small organization to elevate other people, to keep people and to elevate other people to new and more leadership roles, and to have some people join us who I hope are part of our long-term future. So I thank you all for this honor, and I want to now look to the future. Picking up a bit from where Jamila was, and we are so blessed to have you. The title of my talk is Hope is a Strategy. We began this lecture series in 2014 to honor Senator Jay Rockefeller, who was retiring from the Senate. And I hope you're listening now, Senator, I still can't call you just Jay, to hear me talk. We decided to have this lecture series because Senator Rockefeller stood for the best of public service for many of the core values of the Center for Medicare Advocacy. He gave voice to people who were often overlooked. He stayed the course, and he stayed. From Vista poverty worker in West Virginia, he stayed. He became part of that state's community and became the West Virginia's governor and longtime senator. He fought for full and fair access to quality health care for all. Jay Rockefeller knew that he had some power, and he used it to help people who did not. It's my honor to speak today in recognition of his commitment and those values. A few months ago, I was asked to speak at an event sponsored by Connecticut Advocates for Older Adults entitled, Hope is Not a Strategy. I hope to turn that on its head and suggest that hope is a strategy and one I particularly need now. So, being a lawyer, I looked for a site, not Google. The Merriam-Webster dictionary, which has sat on my desk for almost 40 years. Hope, says Merriam-Webster, is the desire for the better, accompanied by an expectation of or belief in fulfillment of that desire, an expectation of fulfillment or success. That's one of our largest challenges now, that expectation. You have to trust that things can be changed for the better, or there's no sense in the effort. You'll hit a wall and be unable to devise effective strategies to advance the change you seek. In my world, that means advancing comprehensive Medicare and access to quality health care for all through a robust, universal, public program by providing excellent legal assistance through an inclusive, excellent, caring organization and community. That we have. The Center has been working to advance these core values since 1986. But for decades now, access to Medicare coverage and Medicare-covered care has decreased. And the Medicare program is wasting vast amounts of taxpayer dollars on private plans, which are too often a giveaway to the insurance industry rather than really focusing on the needs of the people who need and qualify for Medicare-covered care. Medicare coverage and successful appeals are less robust than when we started. Obtaining necessary care covered by Medicare under the law is more and more difficult. And now, the entire social justice enterprise is under attack. Medicare as a universal social insurance program would likely not pass in the current environment. I fear that's probably also true for Social Security and surely Medicaid. So what do we do? As a Jewish sage once wrote, the whole world is a narrow bridge. The main thing is not to be afraid. Have courage. Be informed, thoughtful, and determined to use strategic avenues and alliances to fight on behalf of people in need. Be zealous advocates. Be bold, thoughtfully. Now for a few watchwords. Plan, pivot, and persevere. Plan. What are you trying to accomplish? Who's the audience at any given time? How can you be heard? Pivot. Adapt your message and strategy as things change, because clearly things change. And our strategies have to adapt, but some things remain true. My high school motto, knowledge is power. If you're a lawyer or working with lawyers, that can be your superpower. Don't lose track of what the law really says, and just as importantly, what it really means. Stand strong for that. Find allies. Look around. There is a community. Partner and collaborate with trusted colleagues. Listen to each other. There's power in community. Together, we can make good trouble. Advocate. Tell the stories of the people you're trying to help, like Mrs. Jimmo. Know and use your expertise. Know the law. Use it to be in the game and at the table for the people whose stories you are telling and whose harm you're trying to alleviate. Persevere. One thing I've learned in all these years, a big part of effective strategy is persistence. Whether it's fighting for an individual's insurance coverage or working for systemic change, make it clear, I'm not going anywhere. I've said that so many times on individual insurance fight calls, be it for families and friends in the private health insurance market or in a Medicare case. I'm not going anywhere. We're not going anywhere. We're staying with this fight for individuals and for the broader community. We're going to see this effort through. Perseverance pays off. Take action. Take a lesson from Goldberg, who kept moaning to God, I never win the lottery. I never win anything. Everyone else does. Why not me? Goldberg, said God, buy a ticket. Act. Stay the course with your community and allies. And remember to hope. Thank you, and thank you online and here.
I don't think there's anything that we can say to properly acknowledge Judy or to top that other than thank you. Thank you to Judy. Thank you to you, Judy. Thank you to everyone in this room. Thank you to all of you online for participating. It's much appreciated.
So for now, stay in touch, and we hope to see you next year. Thank you.